Namaste and greetings. I, Fiza Mahajan, visiting researcher at IMPRI, Impact and Policy Research Institute, Prabhav एवं नीति अनुसंधान संस्थान, नई दिल्ली, extend my warmest welcome to you all to IMPRI Web Policy Learning. Today we are gathered here for day 1 of Healthcare and Gender Equity, Emerging Dimensions, Policies, Impact and Way Forward, an online international monsoon school program, a 4-day immersive online hands-on certificate training course. This training program is organized by IMPRI Gender Impact Studies Center. At the very outset, let me give you a brief background on this certification course. Health and gender have had a long and complicated history, with many elements impacting how people of different genders have understood and experienced health. Gender equality has been shown to positively impact health outcomes, both for individuals and for communities as a whole. When the healthcare workforce is diverse, it drives innovation and ensures that healthcare services are culturally responsive and inclusive. Today, the intersection of health and gender remains an important area of inquiry and advocacy. On the one hand, researchers continue to explore the ways in which gender influences health outcomes, and policymakers work to ensure that healthcare systems are responsive to the needs of individuals of all genders. On the other hand, researchers are still investigating how gender affects health outcomes, and legislators are working to make sure that healthcare systems can accommodate patients of all genders. Activists, institutions, and organizations continue to press the development of more inclusive and equitable healthcare systems, as well as for deeper understanding of gender as a crucial aspect of health and well-being. Aligning with the same motive, IMPRI, Impact and Policy Research Institute, New Delhi, is conducting this 4-day certificate training course. This course will aim to deliver the interplay of research, policies, impact, activism, and future developments towards the intersection of gender and healthcare. This program has an excellent panel of experts who will be sharing their expertise for 4-day online certification course. And to begin with, the chair for this program, this course is Professor Vibhuti Patel, and the distinguished expert panel includes Professor Poonam Naik, Professor Mala Ramanathan, Dr. Aksa Sheikh, Professor Sanghamitra Shilacharya, Dr. Amar Jesani, Ms. Sangeeta Rege, Dr. Padma Bhatte Deosthali, Professor Uma Kulkarni. The conveners for this course are Dr. Veena Vaswani, Director, Center for Ethics, Professor, Department of Forensic Medicine and Toxicology, Yenepoya, University, Mangalore, Farhad Yenepoya, Pro-Chancellor, Yenepoya, deemed to be university, and Dr. Simi Mehta, CEO and Editorial Director, IMPRI. I welcome you all to this enlightening deliberation and thank you for putting your time, energy, and efforts into truly understanding the healthcare and gender dynamics and its intersection in the current scenario. Participants would learn from globally and nationally renowned thematic experts and practitioners, gain first-hand insights and networking opportunities, get course outline and reading list from the experts for learning, get access to session videos for 15 days, receive a certificate of completion, and have the opportunity to publish their essays on IMPRI Insights blog, which features articles of eminent people from around the globe. Before we start today's session, I would like to announce the housekeeping rules. It is imperative that you join the meeting on time. There will be a Q&A session after each presentation. Share your questions in the Q&A box and not in the chat box. The questions must not be posted as anonymous attendee. Ensure that your questions are precise and refrain from making general comments in the question to save time. Our session for day 1 will cover topics of gender implications of health policies by Professor Poonam Naik, social determinants of healthcare and gender equity by Professor Vibhuti Patel, and gender in medical education by Ms. Sangeeta Rege. Now, without any further ado, I would like Professor Vibhuti Patel to continue from here and give the opening remarks to the participants. Over to you, ma'am. Ma'am, you are on mute.
Hello, good evening, friends. First of all, I would like to express my heartfelt thanks to Dr. Arjun Kumar, Professor Yenepoya, Pro-Chancellor of Yenepoya, deemed to be Medical University, Dr. C.V. Mehta, Dr. Veena Vaswani, Vithita Fiza Mahajan, and Vaishali Singh for putting this course together and also coming up with a very robust course material, which is circulated today. And welcome Professor Poonam Naik and Ms. Sangeeta Rege, today's expert for the sessions. We all know that interaction of gender spectrum and biology, the roles and responsibilities that society assigns to them, and their position in the family, community, economy, and healthcare system is it's very important to understand. These factors have a great influence on causes, consequences, and management of diseases and ill health, and all the efficacy of the health promotion policies, healthcare services, and programs, and health budgets also. This is confirmed by evidence on gender-based differential in the cause-specific mortality and morbidity and the exposure to risk factors. Health promoting interventions aimed at ensuring safe and supportive environments, healthy living conditions and lifestyles, communities' involvement and participation in the provision of creating systems and structures for the efficacy in the health delivery system, access to health facilities and to social and health services need to be addressed by all of us. And I think we need to understand the differences between women and men, boy and girls, and how the sexual minorities, they face the challenges. So it is very important to demonstrate that health promotion policies that take differential biological and social vulnerabilities to health risks and unequal power relations between the genders into accounts so that we become more successful in addressing the issue and effective, the policies which are formulated can be implemented more effectively. Secondly, we need to discuss what is required to build a multi-sectoral policy response to gender inequities in the health through health promotion and disease prevention. And the requirements discussed should be discuss various aspects of the issues related to health challenges, healthcare, and the health policies, health expenditure, and social determinants of health will be discussed today in this course. So I think it is very important to have understanding, not only as a health professional, but also as a conscious citizen to know about how, and we all have had a very painful experience of pandemic over last 2 years. For the first time, all of us were discussing health issues so seriously. So I think within that, and we were always told that Corona doesn't differentiate between people, between genders, but the social positioning of the people, that is very important in impact of Corona, and that we saw that how different sections of societies were differentially impacted. So with this overarching concern, we have visualized this course, and today our first speaker would be Professor Poonam Naik. She will set the tone by focusing on gender implications of health policies. Thank you.
Thank you so much, ma'am. Now I would request Professor Poonam Naik, Professor and HOD, MBBS, MD, FAIMER Fellow, PGDBEME, Yenepoya Medical College, Yenepoya, deemed to be University in Mangalore, to start her session on the topic Gender Implications of Health Policies. Over to you, ma'am.
Yeah, thank you, Fiza. Very good evening to one and all. At the outset, I would like to thank the organizing team, IMPRI and Center for Ethics, Yenepoya University, and Professor Veena Vaswani in particular for giving this opportunity and this platform to share my views and have an interactive session on gender equity and health policy implications. So kindly let me share my presentation. Is the presentation visible? Can someone please confirm?
Yes,
yes, perfect.
And it's in slideshow mode?
Yes.
Yes.
Yes. Perfect.
Okay. Okay. Thank you all. So my today's session will be on gender implications of health policies. So the presentation would be on the following aspects. We would have a quick look at the NFHS 5 facts and figures and how the discussion with respect to gender and specific focus on it remains relevant today as well. Equity versus equality. How is equity in healthcare? Gender equity in healthcare, planning of health policies, how gender uh, focus on gender as a determinant is relevant, and suggested solutions, tools and approaches to operationalize the commitment. Yes, let us check the facts, have a quick look at the NFHS 5 data. So some of the key, I have just taken some of the key findings, the key variables that hold relevance for today's presentation. So women aged 20 to 24 years who married before turning 18, that is what we call as early marriage or childhood marriage. So this has declined from 27 to 23%, but still we see that 23% is still an alarming figure that needs to be addressed or that needs to be taken into consideration. We all know that child marriage is a key determinant for high fertility, poor maternal and child health, and lower social status of the women, thereby decreasing her decision-making power capacity as well. The number of women who own a house or a land in Delhi has significantly dipped over the past 5 years. So the socioeconomic status and the health, we all know it has a great relation or interaction. Anemia, 57% women in the reproductive age group were anemic in 2019 to 2021, and anemia being the commonest nutritional disorder that has been observed among women, and that can, we all know that malnutrition and infection, these are a vicious cycle which can make the women more vulnerable to infections or to various health problems, and that can reduce their working capacity as well and make them more vulnerable to illnesses. Child anemia rates have also worsened. So women of the reproductive age group, women of childbearing age group, women taking care of the family, we all know that a woman's health is important not only for herself but also for the entire family. So a sick or a ill woman or a malnourished woman cannot raise or cannot give birth to a healthy child. So the after effects are seen during the pregnancy and post-pregnancy as well, making the woman more vulnerable to complications both during pregnancy and post-delivery. It has also been observed that every third child still suffers from chronic undernourishment and every fifth child is acutely malnourished. So this can be related to the poor nutritional status of the women. NFHS 5 data shows that female population aged 6 years and above who ever attended school was 71.8% only. So still we have a larger chunk of them who have not attended the school. Women who are literate is only 71.5%. As I mentioned, women uh, having got married before 18 years is around 23%, a very high figure still. Total unmet need for family planning is 9.54%. That is, they are eligible, they are supposed to use some of the other method of family planning, but these needs are not being met because of various reasons. And health worker who has ever talked to the female non-users about family planning is only 23.9%. So this gap needs to be largely addressed. Women whose BMI is normal, that is malnourished status, it is 18.7%. Non-pregnant, pregnant, both women who are anemic is greater than 50%, and experience spousal violence is a very alarming figure for all of us to note and take some action in this regards. It's 30%. Millennium Development Goals, it was observed that has not addressed gender, or there was not much focus on gender in particular. And however, with the establishment of Sustainable Development Goals, which has 17 goals, of which goal number 5 focuses on gender equality. It speaks about achieve gender equality and empower all women and girls, so their capacity building is essential. We all know gender reflects the continuum of care, right from the childhood to the postnatal, newborn, birth, pregnancy, adolescence, and pre-pregnancy, and thereby their health status is of great relevance. Equality versus equity. What do we mean? Are they the same or are they different? And how are they different? So equality, yes, all have the same rights and status in theory. I believe everyone should be equal. However, equity refers to the application of the principle of fairness in practice. That is, I'm going to make sure I treat everyone the same. So this is a very good depiction. I'm sure many of us here assembled here, the participants would have seen this figure. So it refers to equality, where we give the same resources to everyone. However, in equity, a good number of, or a larger proportion of resources needs to be given to those who are more vulnerable, or who are more predisposed, or who are more exposed to a higher risk factors. They need to be provided with extra support or extra resources. That is what equity is all about. So why equity in healthcare? It's well said, the social conscience is more offended by severe inequality in nutrition and basic shelter, or in the access to medical care, than by the inequality in automobiles, books, furniture, or boards. So it is essential that we provide the basic services, or the basic needs, address the basic needs first, rather than moving forward towards the privilege for someone. Why are we talking about equity over here? We all know health is a fundamental commodity for all of us, and healthcare is an important determinant. But often, yes, we are well aware. Vibhuti Madam spoke about Corona and the healthcare status, and we have all seen that many of the families, they have come down to zero, or they have lost all their financial assets with the onset of COVID, and with serious complications and hospitalization. People have lost their everything due to that particular illness. So thereby healthcare, we all know healthcare is an important determinant, but often it is expensive and yes, unpredictable. Pandemic has time and again shown it to us. And insurance may not always be a perfect solution, or it is not affordable for anyone and everyone. It is not to the reach of everyone as such. Thereby, healthcare should not be allocated or distributed according to income of or wealth. It is essential that it should not be allocated, or it should not be available only to those who can afford it. But equity should be the main principle in making the healthcare services available to all, and thereby the involvement of the government, the different healthcare policies which can make the healthcare services affordable, accessible to the vulnerable. And more so, we are talking about gender becomes more essential, or is more critical. However, what are the concerns then? The concerns that are faced is with the existing distribution of wealth, or the healthcare services that are available. There is inequality, or there is disproportionate distribution of income or wealth. Then why not change this particular determinant directly? And why are we talking only about health? Because we all know socioeconomic status is an important determinant of health status, healthcare seeking services, or healthcare seeking behavior, or literacy, and so on and so forth. Then do we need to address these social determinants of health directly? Equality and equity are not only a matter of social justice and human rights, but they could also improve the quality and efficiency of health systems and services. So it is not just we are talking about social justice by talking on equity, but it would help to improve the efficiency of health services or the health systems that is being provided. Policy agendas now emphasize that when sufficient attention is given to gender issues, the healthcare services can definitely make a positive difference to the health of both the genders. So gender addressing is a highly relevant or highly important. Why focus on gender in the context of health policy? We all know there is an intersection of gender with the various determinants with respect to these are the various social determinants of health which relates to education. We have seen in the NFHS 5 figures the proportion of women who are literate, or the proportion of women who have been married before 18 years. So education plays an important role as a determinant in healthcare seeking behavior, or in access to the healthcare services, or even in maintaining their health, or promotion of health, or prevention of illnesses. So education, nutrition, NFHS 5 figure highlighted the proportion of anemic women and also malnourished children. So that is just one of the figures that I have put across. So there are many such nutrition related issues that do exist. Economic, socioeconomic status, females may not be socioeconomically independent. They may be dependent on others, financial crisis. So thereby that may adversely influence their healthcare seeking practices. We all know about out-of-pocket expenditure. It is not just the direct medical expenditure, but there is also a lot of non-medical expenditure or indirect medical expenses that are related to seeking healthcare services, which could be related to their travel, which could be related to medications, which could be related to admissions. So economic status or economic burden plays an important role. Birth-related complications, inequitable feeding practices. Yes, inequitable feeding practices for the male and the females in the at the household level, or for the male and the female child, or female infanticide, preference for male child. All these are still existing in some parts of our country, though we like it or not. We all know that these still exist in different nooks and corners, and this is what needs to be addressed. Gender and increased susceptibility to health risk. Yes, some of women may be exposed to more vulnerable or more susceptible to certain health related facts when we talk about the type of fuel used. Yes, some measures have been taken, like providing LPG gas fuel to the women at a lower cost or at subsidized rates, but then still it may not be still be able to reach out to the remote areas, or it may not be accessible to anyone and everyone. So there may be still a larger proportion of women who may still be exposed to the indoor air pollution, thereby making them more vulnerable to different health risks. Staying in poor conditions, low socioeconomic status, or in overcrowding conditions, the poor environmental status, no sanitation, water and sanitation facilities being easily available. We had conducted a research on the status of schools hygiene, Swachh Bharat Swachh Vidyalaya. This is one of the programs that is implemented for the government schools with respect to water and sanitation facilities being necessary at the government schools being made available, but we have often found that there are no adequate water or sanitation facilities available in the washrooms, or for washing of hands. There is no adequate facilities available for disposal of the sanitary napkins during the menstruation, and these are the reasons why dropout of girls during puberty happens from the schools, and thereby they become more vulnerable to health risk if improper hygiene exists, or if proper hygiene is not being followed. It makes them vulnerable to reproductive infections, and that leading to reproductive morbidity, and that then reflects during pregnancy, childbirth, and so on and so forth. So gender, we need to appreciate that there is an increased susceptibility to health risk. Gender and healthcare seeking behavior differences. Yes, because of out-of-pocket expenditure, or because of inability to appreciate that health of women is also important. There are poor healthcare seeking behaviors, or there is no support from the family members with respect to this, and so they may reach out to the healthcare centers only at a later stage in times of complications, when the illness may have a poor prognosis. So thereby involvement of the partners or the spouse in all healthcare seeking behaviors at every step is very essential. Gender-based existing inequities in health and gender and health outcomes. So the health outcomes for both the genders may not be same overall. It may be different depending upon their healthcare practices. Research reveals that health policy is gender biased, and thus it contributes to persisting health inequalities. World Health Organization, World Bank, and United Nations have promoted gender mainstreaming approaches, and gender equity thereby must be identified and included in all strategic agendas in the health sector. Yes, our country has implemented certain gender supportive health programs with respect to promotion of their health or prevention of illnesses, with respect to the reproductive and child health, or certain health benefit schemes with respect to safe abortion practices, so as to not have illegal abortion practices being happening that makes the women more vulnerable to mortality or reproductive morbidities. Protection of women from domestic violence, sexual harassment of women, Ayushman Bharat, transgender person protection of acts. So yes, gender supportive health programs and certain acts have been implemented, but yes, there is still a long way to go. How could this be addressed? How could formulation of gender-based or gender-prioritized health policy can happen? What needs to be taken into consideration, or what are the strategic steps that we need to look into? There should be a gender proportion board committee composition. Yes, it cannot be many a times still today. I am sure those who are there in the as in the board, both from the organizer side, Professor Vibhuti, Professor Veena, they would agree with me that still when we look at different programs at a higher level, at the political level or bureaucracy level or at the educational level, many a times we see that the majority of the members of any of the boards or any of the advocacy committees, there won't be equal representation of both the genders. So unless this gender proportion board committee composition does happen, the formulation of gender-based health policy may not be a reality. So this is the first step that needs to be taken into action. Involvement of civil society and expert women's associations. Yes, we need to have the voice of the gender. They need to come in and they know the true problems of the community. They know the field level problems and the field level issues. So they need to be involved. So while formulating these policies, so that the formulation of any health policy is basically, we should be able to bridge the gap. We should be able to address their needs. And this can happen only when the community or the appropriate organizations are a part of such health policy formulating boards. Policy addressing gender in related components needs to have influence on health. So there should be policy not on healthcare related policy, but there should be policies related to the other social determinants. So with respect to education, employment, socioeconomic status, employment schemes needs to be generated, offering education for, as I said, yes, education may be free for the girls, but then education, along with education, we need to also address the water and the sanitation facilities, the facilities for appropriate disposal of sanitary napkins. There should be facilities to provide appropriate nutrition, because if they are not well nourished, they may get infections, and with infection, then it again leads to absenteeism from the schools. So we need to, it is not just health related policies that needs to have a gender component, but the associated components or the associated social determinants also needs to be prioritized to have the overall gender prioritized health policies. Community engagement, yes, the community needs to be involved. Their needs to be understand the unmet needs, their demands or their perceptions, and then plan the health policies. Top down, there should be a shift from we always see the policy is made at the central level and then it is rolled out to the field level, but this is not how it should go out. There should be a shift from the top down to the bottom up approach. There should be a decentralized way of functioning, gender based identification of problems, its prioritization and developing solutions should happen in the local context, because there would be a contextual differences, there would be regional differences, there would be geographical differences, which needs to be understood, appreciated, and accordingly planned. Development of gender sensitive indicators in assessment of health policy making. Yes, at one side of the spectrum, we have formulation of gender health, we have formulation of health policies, but the other spectrum is essential that we develop this gender sensitive indicator the policies. If there are no indicators, if there is no monitoring and evaluation with respect to gender sensitive aspects, then there would not be health policies effectively being planned with respect to gender prioritization. Sorry. Why do we need to have a gender sensitive approach? Am I audible? Can someone please confirm? Because my internet connection.
Yeah, you are audible, madam. Yeah, yes, you are audible. Yeah.
Yes, thank you. Yeah, so why do we need to have a gender sensitive approach to health policy reforms? Healthcare policies and institutions of health are actively involved in the making of gender social inequalities, because it is the healthcare systems which may be, because if the healthcare systems do not have gender appropriate services or gender appropriate policies or gender appropriate strategies, they are the reason for gendered social inequalities that are existing. And thereby we need to have health policy reforms to address this. Research on the health effects of gender policy or the effect of policy on gender differences in health is, I'm sure many of the participants who are attending here also would have tried to Google or tried to search how many research has been conducted with education and health policy, and not many, especially not many in the Indian context as such. So when there is no research, there is no evidence. When there is no evidence, there is no action. Differences in the health status of men and women, yes, and failure in the health system resources, or there is a differences in the human and the social resources that are available for them. We have already seen this at the intersection of gender with various social determinants and how the resources are not equally distributed. Overt discrimination of women is observed more critically across the globe, and persisting neutrality of health reforms that constrains the development of gender-sensitive health policy agenda is also one of the important reasons why we really need to have a gender-sensitive health policy reforms. Let's look at the two approaches to operationalize the commitment to equity, gender, and human rights. It is necessary for monitoring of the health inequality. For this, strong and reliable health information system is essential. Unless we have the data, we won't be able to take action. Health data disaggregation will help the government to identify the health status of the disadvantaged groups. So it should not be aggregate of the whole population, but we need to have gender-based data or gender segregated data will help us to identify the actual problem or address the root of all the problems and take appropriate action. Yes, monitoring of the data and action to address the root cause of inequality. So what I just now mentioned, a strong health information system, appropriate adequate analysis of the data or the information that has been collected, and that will help us to address the root cause of inequalities through appropriate policy and program development and monitoring and evaluation, identify where these inequalities exist and to what extent. As I give an example, when we just did a quick survey on the Swachh Bharat Swachh Vidya amongst the government schools in our district, we were able to identify where are the gaps and what could be how these could be addressed. So such type of research, evidence-based research or system-based research or operational research, what we call about, is essential, because that can then lead to translational research through the evidence that is being generated. Human rights monitoring mechanism, yes, there should be legislative reforms to end gender-based violence, protect and promote the health-related rights, which includes for the migrants, women, children, sexual minorities, and all non-discrimination measures being implemented. Integrate equity, gender, and human rights program. Yes, so National Health Program monitoring, evaluation, reviews does happen at district, at the state, at the center level, but it needs to be more focused, or the equity, gender and equity and human rights needs to be also the core components of these program reviews, because equity, gender and human rights together with the social determinants approach must be formulated as a collective component. It should not be taken as a separate, but it should be a collective component. Research and evidence on who is being missed, who are not being reached, extent of political commitment and budgeting. We all know political commitment, political will, administrative commitment, adequate resources, budgeting is the tool for making the services or the resources available or for allocation. And methods of social engagement, as I said, community engagement, community involvement, civic societies and women forums needs to be engaged in all these activities. Let us have a quick look at this illustrative figure, which talks about how do we address this? Know who is being missed and why. So we need to know who remains unreached and why are they unreached. Strengthen the national plan, system governance and health system functionings to ensure that no one is left behind. Empower the country officers to be leaders for leaving no one behind, and strengthen the health programs to ensure that we reach out to everyone. So meaningful social participation, accountability and non-discrimination are the important components. Yes, so it has been said gender is missing from, misunderstood in, and only sometimes it is mainstreamed into the global health policies and programs. We need to move far ahead so that we do not keep this a reality and we address the concerns. Thank you.
Thank you so much, ma'am, for such an insightful session. Now I would request Professor Vibhuti Patel to give her remarks on the presentation. Ma'am, you are on mute.
Thank you, Professor Poonam Naik. You have provided a very important perspective within which we need to see the health issues, because generally there is always a medical model, or the model which is focusing only on the, as if society, medical practices and healthcare system is functioning in a very, very what you call isolated way, while you have provided the whole socio-economic and also the institutional background, the systems and structures that are determining the healthcare services. So these are very important concerns. There is a question, there are, I think, several questions. One question in the chat box is about why, that is by Roshni Babu. And I think she asked that why has anemia indicators removed from the upcoming surveys in India, and how is it going to affect women's health, maternal health, and children's health, and how are we allies of gender equity countering this kind of thinking?
Yeah, okay. Thank you for that question. Yeah, so with respect to anemia, yes, the NFHS5 has included anemia proportion amongst the women. But yes, if henceforth, if it will not be included, we may just have know the numbers of those who are malnourished, and it would be difficult to pinpoint the exact reason for this malnourishment, or what is the nutritional deficiency that is being seen amongst the community and how it can be addressed. Yes, through different programs, there are measures that have been taken to provide anemia iron tablets, both for the pregnant women, for the adolescent girls, through the ICDA scheme, through the Anganwadi centers, through the schools. Deworming is regularly being happening. So yes, there are strategies happening, but monitoring and evaluation is an important component for any of the programs. And only when we have these indicators, it would be possible to know if through this program are we able to reach out or not. And it needs to be there. Yeah.
But most of the studies have proved anemia is a major killer of Indian women. That is also right from the first report, which was debated in Parliament of India in 1974, towards equality report. That time also we said, and I think gender norms are far more important, because there are countries poorer than India, and they have a better chance. They have less anemia. For example, African countries, like women, this level of anemia is not there. And if we remove that, and if we don't have any data on anemia, then what will be we shooting in the dark in terms of intervention program, health policy? What do you feel as a public health person?
Yeah, so yes, so it is required. So yes, because as I said, it is not just one particular providing iron tablets to them, but there are other many socioeconomic determinants which we have seen are also related. And because of these different social factors or the socioeconomic determinants, the extent to which, even if the tablets are provided, we do not know the compliance as such. So there are various other factors all related, and these could be the different reasons. I'm still in the phase of where we are still having a larger proportion of those being anemic.
Thank you so much, ma'am. Ma'am, there are a few questions from the participants. Ma'am, I would request to Professor Vibhuti Patel to take the questions, or the participants. The participants are also.
So I think
they can also take the questions.
Yeah, you can unmute and ask. Janya Gunani, would you like to ask yourself? Hello, are you there?
Yeah.
Yeah, please unmute and speak.
Yeah. So, ma'am, you actually spoke about developing gender-sensitive indicators for assessing health policies. So, could you just elaborate a little more on that, or give like an example of what those indicators could be?
Can we see you?
Anyone said? Yeah, yes.
A little loudly, we are not able to understand.
Hello, am I audible?
Now, yes.
Yes. Right. Yeah. So suppose if we are talking about, say, I would give an example. Say, suppose about health-related policy, when we are talking about, say, healthcare services, or maybe suppose if I say with respect to if I'm talking about, say, mass drug administration or deworming. Okay, so suppose if this is one of the strategies to combat anemia or to combat nutrition or nutritional supplementation when we are talking about. Okay, so in this, if we can have gender, or if we are talking about even say for example, tuberculosis, say number of new cases detected, okay, or number of cases that have been detected and how many treated. So in this particular, suppose if we have gender aggregated data or gender aggregated gender related indicators, how to what extent have been able to achieve these objectives with respect to the policy that was being implemented. Okay, so suppose if we say lower the neonatal mortality, or increase the increase the immunization coverage, or increase the immunization enrollment. So when we are talking about this, how is it with respect to gender specific? So if this data is available, that would help us to understand whether the immunization coverage, what is the denominator, and how is it with respect to gender aggregated or gender wise data. I think that would be more reliable and to understand in what direction are we going.
Got it, ma'am. Thank you.
There is
Thank
another question by Sasha Nezahara. Would you like to speak, Sasha? Hello.
Yes.
Yes, ma'am.
Yeah.
My question is that recently a lot of speculations have come up in the NFHS data, as well as the BMI is also being speculated if it's a credible indicator recently. So how can we strengthen these monitoring systems? That can we like standardize better, and better monitoring systems appear so that the data is not questioned, and that way we can identify and then act upon it better.
Yes. So what I understand is it was mentioned with respect to BMI, with respect to the indicators, or to the marking system with respect to the adolescents. What should be the criteria? So that was a lot of discussion with respect to that. So yes, that needs to be relooked into. And yes, regarding the monitoring systems or the data collection system, it is like for any other data collection or any other with respect to evidence that we are collecting. It requires a robust system that includes standardized training of, apart from standardized methods or standardized instruments, it also needs to address standardized training methods of the data collectors who go out into the field. And supervising is also essential. It cannot be just that they are trained and they are out into the field. We all are well aware about how the human nature is, or what happens with research, or when we go out into the community, or is it just sitting under a tree and collecting the data. So yes, the standardization of all these methods, training methods, the data collection methods, standardization of the instruments, using a standard method for comparisons, and also putting in a robust scientific method which includes both data analysis as well, is very essential.
Thank you,
And I
ma'am.
think NFHS has overall accepted all the indicators and the definitions of WHO. So that way, the question of biases is not there. I am a chairperson of the Ethics Committee, Internal Review Board of IIPS and NFHS board. And that kind of unethical behavior, or sitting under the tree and writing data, all of us have been in the field of research for 50 years now. So we know that there are checks and balances. So I think that is not the question. But I think some uncomfortable data, because if you show women, so many women in India having anemia, that also like has the international, because currently with G20 and India's inclusion in the ECOSOC, so there are so many other concerns rather than not having robust methodology of data analysis and data. Because all along, we always, when it came to health related statistics, we have always depended on the NFHS rounds, no? And suddenly, when you see such a major and attack on the NFHS method without showing alternative, that okay, no, if not NFHS method and their method of collection of data or analysis, then what alternative do we have? Have we suggested that? Just removing anemia, removing BMI, how does it make Indian health system robust? When you critique something, then you have to also have an alternative. No? In what way this data is not palatable, and what alternative do we need? I think that's a very important mind-boggling issue, which most of the health researchers in India currently, even the global, they are discussing. So I think that there are, I think, other questions also. Amruta Girish, would you like to speak?
Yeah, good evening, ma'am. My question was, I'm
Yeah.
part of a local organization that works very closely with Anganwadis, and considering there's still deficiency in this regard, how can civil society organizations come in to strengthen Anganwadis for combating malnutrition? Madam, you're on mute.
Yeah. So can you please repeat the question? I could read in the chat boxes. How can Anganwadis be strengthened to combat malnutrition in mothers and children?
Yes, ma'am. So,
Right?
yes.
The question
Okay.
is,
Yeah.
how can Anganwadis be strengthened to combat malnutrition in mothers and children? So, yeah.
Yes. Yeah. So the strategy, as we all know, that the strategy that is being implemented is by providing. So Anganwadi has gone through various phases of implementation. At some points of time, there was hot cooked meals that was being provided. Later on, it was like the take home ration that has been provided. So there have been different of pros and cons of each of these strategies. So the extent to which, so there are at various levels, there are these challenges, or there could be action that could be taken. So first is the hot cooked meals. So what proportion of the beneficiaries who are enrolled in the respective Anganwadi center, do they come to the Anganwadi center for consuming the hot cooked meals? So are they actually getting the supplementary nutrition that they are due for? Because as I said, I'm from community medicine, so we work in the community. So when we go out, when we interact with our antenatal women or mothers of under 5 children, many a times we come across that many of them are not beneficiaries of the Anganwadi in the village or the area where they stay. So the pregnant women wouldn't have approached or wouldn't have received the supplementary nutrition from the respective Anganwadi, or the child is not a beneficiary from the Anganwadi. So the first and foremost challenge is to ensure that they are enrolled. After they are enrolled, are they receiving the supplementary nutrition that they are due for? Because at times when it was hot cooked meals, is it very easy for the mother or for the pregnant mother or the mother of an under 5 child to bring the child? It is not just next door. So the geographical accessibility or other cultural factors do play a role. So are they getting that particular supplementary nutrition what they are due for? Next, even with respect to, yeah, anyone? Yeah, so even when it comes to Professor Vibhuti, you have to say something. Yeah. So even when it with respect to take home ration, so the why it was changed from take home ration to hot cooked meals was because the ration that is being provided, it may not be it may be consumed by all the members of the family rather than the particular individual who is supposed to have it. So the services of Anganwadi center or the strategy, it has gone through different ways of implementation, but each method of implementation has its pros and cons. And one more thing, I feel that yes, their enrollment, and yes, Anganwadi workers do try their best to get them enrolled, but we all know our health systems, how overburdened all these grassroots level workers are. Sitting in the uh, sitting in the offices and making the health policies and national health programs and its review is a very easy task to put it on paper. But when it comes to the field, those field workers, the grassroots level workers who are the frontline workers, for them to implement and ensure that their program is implemented as per the guidelines is a very challenging task. And we all have seen the COVID times. Apart from their activities, utilized for the various activities with respect to COVID, and all other activities took a backseat, especially immunization, non-communicable diseases and all. So that's a major issue at that point of time also. Yes, so we need to
Dr. Shruti has a question. Would you like to speak, Dr. Shruti? Yeah.
Yes, ma'am. Thank you for addressing my question. First of all, thank you, Professor Poonam Naik, for this insightful talk today. I wanted to understand, healthcare MNCs, pharmaceutical or the med device sector, they contribute to a major chunk in the healthcare industry. So how possibly, that collaboration can build up? What could be the strategies or possible way ahead in implementing gender equity at grassroots level?
Collaboration with?
The healthcare industry, pharmaceuticals, and the med device industries.
Okay, fine. Yeah, so pharmaceutical is one, medtech is another one. So pharmaceuticals, yes, with respect to certain national health programs, involvement of, especially if you are aware of the National TB Elimination Program, with involvement of pharmaceuticals is one of the major components that has been roped in. So with respect, because we all know patients, they just go and purchase over-the-counter medications. And this cannot happen with respect to TB, because we need to know the patients who have tuberculosis, do their contact tracing, reach out to their families, and so on and so forth. So of the pharmaceuticals training, notification by the pharmaceuticals with this respect, and giving appropriate data is one of the components that has been maintained in this particular program. So yes, there is a scope, but yes, again, then we all know, as we all know, that it's a developing country and we have the burden of every illness is huge. So we are in the progressive phase, I would say, but we can always explore this possibility. With respect to medtech, yes, so make in India, smart India, digitalization, and any other devices that we have which can be used specifically with respect to, suppose it is with respect to the field. There are many such medtech related uh, uh, that is coming up in the recent years. Our university also does have an incubator, which they are working on. We have various Sparsh fellows, which is funded by the BIRAC and so on. So we also do, our institute is also working on many of these aspects as well.
Thank you, ma'am, for your
And yes,
answer.
medical in today's era of technology, I think there is a very large scope for medical field or the healthcare field and the technology to hold hands together and move forward.
Absolutely.
Roshni
Thank you,
Babu,
ma'am.
would you like to ask your question? Earlier when I had announced, you have asked another question in the
Yes, please.
Q&A box.
Thank you, Professor Naik, for this wonderful presentation that has set the stage for all these questions that we're asking related to gender equality and gender equity. So what I noticed is 18 out of the 29 states in India have achieved the SDG goal of TFR, that is the total fertility rate. There was a huge reliance on women's family planning in order to control the population, although I hate the term control population. But there was an over-reliance on women, whether it is sterilization, whether it is contraceptive pills, etc., as if family planning is only the responsibility of women. Okay, despite pharmaceutical companies coming up with the male contraceptive, that did not, gain traction at all, because women are doing the service. Why should you stop them from that kind of attitude? Now that 18 states have reached the TFR, and there is population stabilization, are we going to move away from this over reliance on women for family planning?
Okay, yeah, so family planning, again, I would say, first and foremost is, so here we all know about the behavior change, communication, or the knowledge, attitude, practice gap. Yes, so acceptance of family planning methods or the decision to accept a family planning is itself, again, it has many large social determinants attached to it. So as we say, for health, there are many social determinants which needs to be addressed. It cannot be just directly that we can directly provide health services and the health status would just go beyond the bounds. So same it applies for family planning also. Unless we address these other social determinants like literacy, their educational status, employment, because only when the female sex or the women would have education, appropriate literacy, or adequate information, they are financially independent and they are not dependent on someone else, because that would give them the decision making power or the decision making capacity. So till these social determinants are being addressed, uh, uh, we expecting that a sudden change would happen from women family planning to male family not be immediately possible. Yes, these other social determinants really needs to be addressed to a larger extent. It's basically all about the decision making power or the decision making capacity.
True. I agree
And that is
with
why we
you,
still see
but
in the
we've
tribal
also,
areas, and rural areas, we still see what is the extent of antenatal care that is being provided to them.
true.
Are they coming
True.
forward, or do they come only during the delivery?
True. But during the pandemic, we saw that most of the educated women who were employed had to give up their jobs in order to take care of their elderly people who were sick, etc. So education and financial independence, of course, they are so determinants of empowerment of women. But in a patriarchal society, there's hardly anything that happens because ultimately, women have to sacrifice everything.
That is true. That patriarchal bias is there. Women don't having decision-making power.
Yes.
Yeah.
Yes.
Fully endorsed. But now I think Dr. Poonam Gaikwad, would you like to unmute and speak? Hello, Dr. Poonam
Good evening,
Gaikwad.
ma'am.
Yeah, a question.
Yes, ma'am. Am I audible?
Yes.
Yes.
Yeah, good evening to the panelists, and thank you so much for the presentation. My question was coming from the point where Professor Poonam touched upon the fact of, life cycle approach. A girl who is in not good health at her adolescent, that cycle follows during her pregnancy, childbirth, giving birth to the undernourished child, and the cycle repeats. So my question was, what are the current interventions in the national health programs which are currently focusing on adolescent health? Because a girl goes very differently into a puberty compared to a boy, and how the programs are being, catering towards this particular issue, especially that particular age group which cuts upon the child age and adolescent age group. Adolescent comes from 10 to 19, and we don't see much interventions around this, and which data to be looked upon, because all the data is on women health and child health, but nothing as such majorly focusing on adolescent health. And lastly, if there is no such data, how do we who are working in public health especially have to align our programs or research in specifically in this particular domain?
Yes, there are national health programs with respect to adolescent health. So when we talk about RMNCHA plus, and that is reproductive, maternal, neonatal, child, adolescent health and nutrition. So that does have an adolescent component through which in the health systems they do conduct that adolescent friendly health clinics, which are called as AFHCs, and there is this strategy which is called as adolescent reproductive and sexual health strategy, that is ARSH. So the major components, so there are these adolescent friendly health clinics being conducted in the health centers on a weekly basis. In Karnataka, I know of, it is called Sneha clinics. Sneha means friendship. I'm not sure of how is it called in the different states. Basically, it is related to the local nomenclature. So these clinics are being conducted in the healthcare centers. Yes, and they are supposed to provide services with respect to life skill education, menstrual hygiene, puberty, deworming, iron tablets, and also in the schools as well, life skills under the National Service Scheme, NSS. So there is this they have the provision of, or they have the policy of conducting life skills education for the students, the schools all over the state, all over the country. But yes, because of resources, we all know, because of resource constraints or because of limited resources, reaching out to each one and everyone becomes a challenge. And when I talk about adolescent friendly clinics in the health centers, as we know, this falls in the 10 to 11 year age group, when they would be either going to schools, or if they are going to colleges, depending upon if they are staying, if they are pursuing their education, then coming to the clinics during that particular point of time again is not a possibility for them. But yes, there are provisions in the national health programs. These aspects have been addressed, but maybe it needs to be more strengthened, because I would say reproductive and child health was one national program which was earlier existing. If we begin from, it was like maternal and child health.
55% of the
Then it
union
moved
budget
forward.
on women was going on RCH earlier.
So
Till
then it
I
moved
think
forward to
2019
RCH.
also. Yeah. Union
so then it
budget
moved
for women and child development's budget, 85% for RCH. Earlier.
So earlier it was MCH, from MCH it moved forward to RCH, from RCH to it has moved forward to RMNCH, then RMNCH plus A, and even Anganwadis we were talking about. Through Anganwadis also there is a program called as Kishori Shakti Yojana. So this is also one of the components for adolescents. Yes, so steps are being taken, but not as much as required, or maybe it requires, we are a long way to go, or it requires strengthening everything again based on the resources, but it is what is required.
Now we have Britika. Britika, would you like to speak?
Yes, good evening, ma'am. Thank you for your session. So my question to you is that postpartum depression is a huge concern in mothers. As you said that neonatal mortality has reduced, but there has also been an exponential increase in the number of children with birth defects and developmental delays. So if a child is born with congenital disease, the mother as a primary caregiver has to have an extra burden. If she's already suffering with postpartum depression and if the child has congenital defects, then the mother is already at risk. So what gender sensitized approaches can we put into consideration to address this issue?
Yes, with respect to postpartum depression, even presently even antepartum depression is on a rise. Okay, so one of the, even in our hospital and our community areas, we conduct what is called as mothercraft clinics. So these mothercraft clinics are basically health promotion and health education, both for a group of antenatal women as well as postnatal women, where we begin providing basic information with respect, starting right from physiology of pregnancy. So physiology of pregnancy, family planning, childbirth, child rearing, physiology of lactation, home economics. That is also one of the important aspects. Nobody's talking about it. See, when there is a new member that would be added to the family, antenatal care requires antenatal health care, would lead to additional financial expenditure or burden for the particular family. So these are certain strategies that are being suggested, recommended, but see, as I always say, there are national health programs, there are health policies, there are structures to implement. So, but what happens is many a times it doesn't get implemented because of our limitation in resources. But yes, this is one of the mothercraft clinics, is one of the strategies through which this antenatal depression or postpartum depression can be addressed to some extent. And yes, in OBGY department is also presently there's sensitization going on in many places. I'm sure all of you would also have come across it, that they are supposed to assess the antenatal and postnatal women both, not just postpartum depression. Presently we have been talking about antepartum depression also. They need to be assessed for depression during their routine healthcare visits also. And yes, child born with congenital defects, it needs to be taken care of. Again, there's a national health program which has been implemented with respect to this, that is RBSK, Rashtriya Bal Swasthya Karyakram. So where the children are screened for 4 Ds, that is the childhood congenital defects, developmental delays, nutritional disorders and diseases, where they need to be screened for, and appropriately they will be tagged along with the government health system for further treatment and management. And in Karnataka, I would say that there was one initiative that was being taken where there was a public-private partnership where the government and the private, because there are many medical colleges, they together conducted this RBSK camps in different taluk area. So our medical college was also allotted one complete taluk for conducting RBSK camps, and whichever children were identified under the 4 Ds of RBSK, they were then referred to the next district level for a further support and management.
Thank you.
Now, Amruta, you have a question on mental health. I think we leave it for the other resource person. The last question by Anushri KN.
Yeah, it's already 7 o'clock.
I've asked one question, so you can ask the same question elsewhere. Yeah.
Yes.
So Anushri KN, can you unmute and speak?
Yes. Am I audible?
Yes.
Yes. Good evening, ma'am. My question is slightly different. The recent data of NSS between 2014 to 2017, 18 or 19 shows that women tend to use more of hospital care vis-a-vis men, irrespective of the age, right? Even after taking in, discounting the delivery part or the OBG part, right? Given if and only if this data to be true and accepted, then what could be the gender implications on equity? Because whenever we speak of gender equity, it comprises of both the gender, I mean, not just the binary, but even the transgender, right? So what could be the healthcare implications in terms of equity?
Can you please repeat your first section of your question?
Okay, the data reveals, NSS data, recent data reveals that women tend to use more of healthcare services compared to men, irrespective of the age group, even after discounting the hospitalized cases because of delivery, right? Even if I take out those subsect of the group, still women tend to use relatively more of healthcare services compared to men, right? Uh, which which essentially means that there's some sort of a gender disparity with probably regard to men. Whenever we talk about gender equity, it is largely skewed towards women's health and women's health outcome, while certain such things get really masked as part of gender equity. So what could be the health in policy implication if this continues to be so, right? Yeah, probably I would like to hear from you.
Okay, so can you please on whether the data was with respect to the government health systems, or was it with respect to the private as well, or
Irrespective of the service provider?
irrespective of the service provider? Okay, I'm sorry because I have not come across this particular information.
I'm also not.
But Professor Vibhuti?
Yeah, I think you in the next lecture you can bring the evidences, because I have also not come across women health seeking behavior. In fact, all the area studies and micro studies, including that of Padma Devastali or Neha Medivala, all of them are showing that women generally depend on the home remedies. Even during the pandemic, we saw the hospitalization rate. Sathi study shows that it was men who were more hospitalized than women, because women, along with their COVID, are also looking after their families. So I think,
yeah, this data was just before COVID, between 2017 and 18. Yeah, so
yeah, I think, yeah, you just give us the data and then we'll be able to answer. Yes, over to
maybe
Fiza.
maybe a keen look on the data with respect to the type of services, or what was it that the women were accessing. Maybe that would help us to
the children
provide, or
maybe they were accessing more for the children's health or elderly people's health or some family members' health. I think reason for accessing healthcare we
for
should
accessing
know.
the healthcare services. Yeah, maybe that would help us
Could
to
it be, ma'am, that it
on
is
that.
more one time than the trend?
so slightly between 2014 and 17, like probably two sets of data points. It's, I mean, if this kind of trend emerges over the years, then it will have some sort of a implications on gender equity, right?
Possibly, and certainly, yeah.
Yeah, definitely. So it is not that we have been talking about gender equity more with terms with respect to women, because it has been observed that they are more vulnerable. There is the life cycle approach that applies to the female gender, and because they are more predisposed to different health risks, and they do not have the decision making capacity with and we all know the socio-economic determinants which were discussed about. So because all these are covering the larger umbrella below which the women is standing, and thereby equity more with respect to women. So when maybe this change happens, we're talking about gender equity with respect to both the genders. Because it is not that I don't think we are talking about something ki nari ki jai ho or anything of that sort. Basically, we are talking about it is the vulnerable group, it is the predisposed group, which also needs to be provided healthcare services and which needs to be addressed. And we are talking about equity.
Thank you so much, ma'am.
Yeah, thank you, thank you.
Now moving forward from this extensive Q&A discussion, I would request Professor Vibhuti Patel, visiting distinguished Professor IMPRI, to start the session. She will be taking the session on social determinants of healthcare and gender equity. Over to you, ma'am.
I think
thank you
has
all.
Dr. Sangeeta joined, because now I don't want, yeah. So I don't want to.
Thank you for the session.
Yeah.
Thank you.
Thank you. Thank you. Yeah. So Dr. Sangeeta, has she joined?
Yes,
Yes,
Vibhuti,
I
hi,
don't
good
want
evening.
to. So Sangeeta, you want to go first because your time is precious.
How do we, or do we share the session? I mean, I'm happy to do it whichever way you let me know.
No, my session is on social determinants. And after that, yours is on gender in medical education.
So you decide the
you
flow.
want-
Do you think I should, maybe I take about, I know the time is precious. So you want me to do it like in 30 minutes? I will leave it to you. And then you can take over.
Yeah. Otherwise, I can post. Yeah.
All right. All right.
Go ahead.
Thank you.
Okay, ma'am. Now Ms. Sangeeta Rege will take the session forward. She is the coordinator, Center for Inquiry into Health and Allied Themes, CHEAT, Mumbai. To take the session, she'll be doing the presentation on gender in medical education. Over to you, ma'am.
Thank you so much. Thank you, the entire IMPRI team and Professor Vibhuti Patel. This is my second time, and I'm always amazed by the way the team organizes this entire, workshops. There's always something to take away. And I see that it's evening and there are so many people who have already joined here. So I will keep my session to about 30 minutes, and we'll try and infuse it with a couple of videos. And, happy to take questions either immediately after the session or Professor Vibhuti's session. After that also, I could take them. So a little bit on SEHAT. SEHAT is a Center for Inquiry into Health and Allied Themes. We are almost a 30-year-old organization, and Professor Vibhuti Patel is one of our founding trustees. We were set up in 1994. So what I really plan to do is take off from previous professors' presentation to really do a slightly more deep dive into gender, sex, because we often see that the way medical education looks at the issue of gender, sex is often synonymous, though we all know that it's not. So I thought, let's have a quick fun exercise so that it'll lighten up the mood. Then I'll quickly go to a more recent research study that we did at SEHAT to understand what are the gaps as far as the clinical practice is concerned for women, trans people, and so on. We are calling them as gender minorities in case of my presentation. Then we look at how gender affects different health conditions. And then we end with a quick about 6-minute video. Yeah. So I'm going to show you a couple of silhouettes, images, and I will request people to either unmute. Actually, unmuting is better than you putting it in the chat box, because then that will make me again go back to the chat. So I'll show you a couple of silhouettes, and I quickly want you to answer. What immediately comes to your mind? Is this silhouette that of a male, or is it that of a female, or you think that it could be either? Yeah, please don't take too much time. It's a quick thing. So we want your immediate, unfiltered responses. Yeah. So could you please unmute yourself and tell me, do you think this is a male or a female, or it could be both? Do you want me to go to the chat box and read it, or do you want to unmute yourselves, members? Okay, everybody says it is female, but there's Dr. Shruti who says it could be either. All right, let me go to the next, sorry, the previous one. What about this one? Okay, could be both, could be either. All right. This? Okay.
What about these? Yes, it's mixed, but what do you think it's overwhelmingly? Is it overwhelmingly male as female? Or okay. This one? Okay. So the potter looks like most people have responded as male. What about this one? Okay, largely female. What about this one? For some reason, I am unable to. Okay, so some people have said it's a female, it could be a mom. All right. Okay, so that was the end of the silhouettes. And, I wanted to show that a lot of our colleagues and friends right now said that, some of the caring roles, the silhouette looked like it was women, but some others differed and said it could be both, right? So the one takeaway, except for the one image where there is a woman who is shown to be breastfeeding, almost all other images are really about gender roles. And the good thing about your responses is that gender roles can be changed, right? So if we go back 50 years and if we saw that one particular silhouette where you saw a person who was frying or cooking something, 50 years ago, all of us would have said it's largely a female. But cut down to 2023, the responses are mixed. That's a very clear indication amongst us that gender can change, right? And that is true for all of the other roles. So I would request you to keep that in mind, that gender is not static. It can change over a period in time. It can change from region to region. And so we often say that gender is like a software and the patriarchy is like the hardware. And I want to just leave you right now with that thought and not do a deep dive. But for those of you who could possibly be teachers, trainers, this is also kind of telling you that, this silhouettes is something that you could use with your own students to create or generate some kind of a discussion. So there are two essential concepts that everybody must be familiar with, right? The ones who've done their MBBS, MD, the ones who are MPH, the ones who are MHA, the ones from social work field and so on. And yet in our practice, right? In our practice, this is often something that gets intertwined and mixed. The point we need to constantly remind ourselves is sex is a physiological aspect. It is a characteristic with which we are born. It is something that is given to us at birth, right? While gender is something that we imbibe over a period in time. And gender comprises of a battery of things. It could be gender roles, something that you saw in your silhouettes right now. It could be the expectations and obligations that men and women need to fulfill across different cultures, Indian, Western, and so on. It could also be a certain value that is either attached to being a male or removed from being a female. So that's something that you see as far as the gender role is concerned. So do you think that there is something that's missing over here? There is something that I have missed on. I think there was a previous colleague who raised the issue, I think, of trans people. So, in gender identity also comprises of a transgender identity. And similarly, sex identity also comprises of intersex identity. So research shows that we're not just restricted to XX chromosomes and XY chromosomes, but there are several combinations and people fall across these different combinations. right? So intersex is a form of sex. And that is something that I think we need to remember, especially those in the health sector, those in the medical profession. And I'm saying this because often gynecologists, at birth, and obstetricians, when they deliver babies who are with ambiguous genitalia, themselves don't know how to disclose this to parents and also how to support them. And they themselves also feel very, very confused. And the problem is that the MBBS curriculum does not really prepare doctors, or the MD curriculum of gynec and obstetrics does not really prepare doctors to understand sex variations and to understand that intersex is also a kind of sex. So there's an immediate push to kind of design or use the scalpel in a manner that if there is a little bit of male sexual organ like a penis, then a surgery would be conducted in order to make the baby a male, or something like the genitalia looks a little bit like the female, and then the reconstruction could be around a vagina. But often research, even in the Indian context, has shown that if you, hasten the process of assigning sex at birth with ambiguous genitalia, then such children will constantly feel a sense of dissonance. So global literature, global evidence expects that we counsel parents and we ask parents to observe child's behavior over a period in time, only after which, if the child feels more like being a boy or a girl, and accordingly at a certain age, pre-pubertal, that kind of a surgery, if at all, could be carried out. So that is something that research right now is indicating to us. This is a Lancet piece, and I thought it was interesting, so I've just put this out. I'm going back again to the area of concern, which is all around gender roles and gender norms. And if you look at this image, it's very clear that gender is culturally defined because sex is biological and gender is not. So we are born with a certain sex, but then a set of responsibilities are actually placed on being born a XY or a XX. And these are attributes that over time get formulated on how women should behave and how men should behave. So for example, there is no research evidence to indicate that women are fragile, women are emotional, and so on. But that is something that is there in, I would say, the dominant understanding of how women are over a period of time. And similarly, men are expected to be masculine, aggressive, not demonstrating their emotions, and so on. And this is something that gets perpetuated in the system quite often. And how does this affect access to healthcare? So again, going back to the previous presentation, a lot of times, because of the gender roles, because of the gender norms, women may also seek healthcare at a much later stage. They may actually end up, as Professor Vibhuti spoke about, they may actually end up going to quacks, trying out different kinds of things at home remedies and so on, till a time doesn't come that the woman is just unable to function. And that will be her last resort to actually go to a health system. Often women are dependent on others within the family to take them to a healthcare system. If a woman is not working, then her health is really not a priority, because it's not looked at as she generating the same kind of income as a male. Vis-a-vis cut down to men, because they have much higher workforce participation, they also have more financial autonomy. Their health services are also prioritized. And that's the difference that we see. There are several other soft issues about, healthcare providers' perceptions about men and women, and how is it that they present their health complaints in a formal health system. A lot of times, and there are studies that are done on how even the health system stereotypes men and women. So often there is a notion that, at the drop of a hat, women will access health services. They will access health services for even the more non-serious kind of things. They're just looking at taking a break from home and coming here. Their pain threshold is much lesser than men. But none of this actually has evidence to it. But this is something that has been perpetuated over several years in different contexts. So this is an interesting, slide, and I have titled it as commonalities in gender differences. While we value gender differences, we do not need to create a hierarchy on what is more important and what is less important as far as the men and women's roles are concerned. So as we clearly know that, men and women, boys and girls perform different roles, and so they occupy different physical spaces. As you know that over a period in time, you have more workforce participation by women. But again, it is seen that most women are participating in informal work spaces, in spaces where they barely have access to health insurance, access to social security, and so on. So even if you see a heightened increase in workforce participation, it's not really in the formal sector, and they have very little access to proper healthcare. We also see that as men and women are growing up, the family, the community, and institutions are passing on certain gender norms, which expect that boys and girls will behave differently. So, for example, what is an appropriate dressing for boys will not really be appropriate for girls. If, for example, there are girls and boys who are interested in skills that don't really fall into the, very mainstream occupations that men and women have, then efforts will be made to kind of put them in a box and say, this is not what you're expected to do. And I can give you an example here. Some of the best chefs in the country are male, but when it comes to our own households, it's often women who are cooking in the houses. Similarly, you see that as far as the profession of dress designing is concerned, that often tailoring as an occupation is really very male-centric. But a lot of times, if you see at home, it's women who are mending clothes. But also you see the reverse. For example, now there is a progress, and you see women in sports, women in boxing, women in, cricket, and so on. But what happens when men decide to stay at home? When men choose to be homemakers, that is not something that is taken kindly at all by the society. So the point I'm trying to make is that gender can also backfire negatively against men. And that is the reason that we need to dismantle gender. Just to say that access to resources and decision-making is different for men and women. And that is something that I think we've been talking since the first slide. This is just a quick slide to indicate what are the gender inequities as far as health system is concerned. If you look at most of the research studies globally, most of the biomedical research is done on a typical male, and those findings are often extrapolated to women, whether it is about certain conditions like the coronary heart diseases, the medication for it, the dosages are then adjusted for women. But if you largely see the studies, they really are done on men. Similarly, if you look at formal health systems, whether public or private, whether medical colleges or the private sector, the distribution of power and leadership is most often male, right? And though you will have women doctors, often the administrative hierarchy is placed among a few men in the system. Lastly, those who have diverse gender identities. When I say diverse gender identities, I mean trans men, trans women, men in same-sex relationships, women in same-sex relationships. When they end up disclosing their identities, it's very difficult for them to access health services. There is a lot of stigma. There is also a certain stereotype about people in same-sex relationships. They're often understood as having STIs, including HIV, almost like other healthcare needs for them don't exist. And those kinds of associations are very, very dangerous. In fact, a study that Sehat did in the recent past showed that, when people who obviously look different, which are trans people, are accessing health services, and they actually are telling the doctor or the nurse that I feel uncomfortable if I'm admitted in a male ward. Could you do something differently? Pat comes the response that, women are so scared. What if you sexually assault somebody? We cannot have you in the female wards. But there are ways of negotiating that spaces. And there are ways of making people comfortable, because they're there for health services. And an interesting innovation, I would say, has happened in one of the public hospitals in Mumbai. It's a government hospital, it's Kama Hospital, which has now created an entire ward for trans patients. So while that's a first important step, the point is that just creation of a ward is not enough, because the staff of the hospitals needs to be sensitized to trans healthcare needs. A lot of publicity needs to be given about access to services. So in the last 6 months, the hospital has only got 5 patients. Does this mean that trans people don't need healthcare? No. It just means that there is no awareness on availability of wards and on accessibility. So, you create something nice, but it's not even accessible and people have no knowledge that such a ward exists. So that brings us to the critical question on how does one uncover the root cause of these inequities, and what is the way for us to really create a response that is sensitive and appropriate to the different needs of people. Vibhuti, please just tell me if I'm over my time.
No, go ahead.
How much
time
do I have?
Another 5 minutes?
Yeah, sure. So I've just put over here a couple of images, and I will share these slides with the organizers. But we're looking at the last 1.5 years, and there are several articles that are talking about gender inequities leading to health inequities. And I've put out 5 articles here. One is on unnecessary hysterectomies amongst women who are in the farming community. The other is around the piece that I spoke about, which is using male as your model for conducting any biomedical research and then extrapolating those findings for women. And then interestingly, there is a study that was done in Mumbai to look at causes of death. And the causes of death in women indicated that 1 in every 5 women in reproductive age groups were actually dying of unnatural deaths, which were aspects like burning and drowning. And both, are causes of concern because they are unnatural. So either, it is an attempt to homicide or suicide, and there is a requirement to do a deep dive. This is just another thing. I think the previous speaker also mentioned about the problem. So if you look at the current health budget, the increase, there is no increase, one, and the minuscule increase is really the inflation. And it's so sad because on one side, you have all of the new different mental, healthcare acts, like there's the Mental Healthcare Act and so on. And then there's a trans healthcare bill and so on. But where is the money? Where is the money really to ensure provision of these kinds of services? So the policy doesn't really lead to increased funding anyway. And sometimes it just feels like lip service. I don't have too much time over this, but this is a study that Sehat conducted across medical colleges in Maharashtra. And you won't believe in 2022, these are the views of medical teachers in premium medical colleges of Maharashtra. Something very common is stereotyping of women patients, instances of labor room violence, interface with transgender community, and, blaming trans people for not disclosing their gender identity. So these are a couple of problems. I will quickly go to what is the effort that my organization has made. So as you all know, that the MBBS curriculum has been overhauled in 2019 through a mechanism which is called competency-based medical education. And the focus is on non-didactic teaching, and the effort is towards integrating at one level social determinants of health, but at another making it really more reflexive by actually testing competencies of medical students. So this is a welcome approach. But because it's very recent, this is something that has to be tried over a period in time. Sehat conducted an experiment almost 9 years ago, where an entire exercise was done in collaboration with medical teachers of several government medical colleges in Maharashtra to really comb through the 5.5, 6 years of MBBS curriculum and look at the gaps in that, and look at the gender gaps in that. And based on those gender gaps, efforts were made to integrate gender perspectives across the MBBS curriculum, not just relegating it to one particular, lecture in the beginning of MBBS 1 and then having it, in the 5th year. So this is something that needs to be taught over and over again and integrated across the board in the medical curriculum. The result of this was creation of gender integrated modules for 5 core disciplines, the discipline of gynec and obstetrics, forensic medicine, community medicine, internal medicine, and then psychiatry. And at that point in 2016, 2017, while we had a championship of about 25 odd medical teachers from Maharashtra who taught the gender integrated curriculum, the biggest concern was, is this feasible? And, will this increase teaching time? Because that's not something that is possible for medical teachers to give time over and above the allocated number of lectures that have been given to them. Because besides they conducting lectures, they also have to conduct what you call as OPDs and IPDs and so on. So we carried out a research study to assess the feasibility of integrating gender concerns in the undergrad education. And surprisingly, even in medical colleges which were remote and had very poor MBBS student attendance, the attendance jumped by almost 70%. And friends, one of the reasons for the jump in attendance was because teachers had given up didactic teaching. They were using different methods. They were using case discussions, they were using debates, films, and so on, which did stir medical students into getting more cued in and interested, even in the biomedical lectures where, gender was integrated. And interviews across teachers did indicate very strongly and clearly that this is something that is feasible to teach in the existing number of hours in the medical curriculum. So equipped with this evidence and this knowledge, we have now expanded to different states in India. We are working with the state of Karnataka, Bihar, Telangana, and so on. So if you look at this is the Gender in Medical Education website, and I will request all of you, to look at this website. You can even go to the Sehat website and look for this. It's got different, blogs of medical teachers who have integrated gender concerns in their medical teaching. It has short films that have been used basis how these teachers have conducted the actual classes. They have research studies on it. So there's a host of, it's a repository. And please feel free to, kind of access it or reach out to me. I'm happy to do either. These are just a couple of pictures of a recent GME workshop that was conducted in Karnataka. Yeah. These are how the modules look. And again, all of this is on our website. So this is just, I'm going to end the slideshow with just 3 basic elements. We've divided social construction of gender across the board into gender analysis in health, gender and sexualities and sexual and reproductive rights, gender-based violence, gender ethics and rights. So these are the 4 themes. And, we don't have adequate time to go through what is covered in each of these themes. But as you can see on the slide, the gender analysis in health really enables medical students to understand the issues of family planning, access to contraceptive care, how do communicable diseases affect access to healthcare, health outcomes, and so on. So that is something that is being done in the entire gender analysis and health, which is a part of the medicine discipline as well as the community medicine discipline. Then you come to the gender and sexualities and sexual and reproductive health issues, where several issues around sexual orientation, gender identity, talking about adolescent sexuality, talking about autonomy and decision making as far as access to abortion services are concerned, and so on. Gender-based violence, I don't have to tell you much. You will have a full session on it. But just to talk about how gender-based violence impacts access to health services, there are several health implications that people face as a basis of gender-based violence. How do you clinically identify these signs and symptoms? And to end, there is the gender ethics and rights. And we raise several ethical dilemmas around virginity testing, sex verification tests, something that is used in the sports, and how it is absolutely anti-women, dealing with intersex people and creating ethical guidelines around that. And finally, talking about obstetric violence in the labor rooms and thinking of ways of preventing it. Yeah, this was it. And I quickly wanted to show you one film, if the organizers can permit me. Is it okay to show the film?
Yes, Sangeeta, please go ahead.
Yeah, it's just like a...
Yeah. My presentation I will use as a concluding remark, because most of the points have been covered by you and Dr. Naik, so that's not a problem. Go ahead.
Okay, thank you. Can you all see this?
Are you spending hours and hours of time editing your images to get that perfect? Medcram.com. Welcome to another MedCram Cope.
I don't know, for some reason.
Medcram.com. Welcome to another MedCram COVID update. We're going to actually talk about long.
Can you make it full screen?
Metabolic health.
Yeah,
when it
I'm
comes
just
to
wondering why the
diabetes.
Sehat film is not coming on. Here it.
Okay, it has come.
Yeah, but when I play it, no, Vibhuti, it's some. Okay, let me start here.
It has come. Only thing, now make it full screen so that all these other videos go on.
Medcram.com. Welcome to another MedCram COVID update. We're going to actually talk about long. Medcram.com.
It's something
Welcome
completely.
to another MedCram video. Today we're going to talk about the
Earlier
treatment
it came.
of
It
asthma
came
and
earlier.
COPD, and
Yeah,
the treatment of
sorry, I have to
COPD.
stop this. I don't know, for some reason.
Medcram.com.
Now it's correct.
Yeah, but I'm trying to play the same thing. I just don't know why.
It will play, ma'am. Just go there.
Can you please? Yeah, I had sent you the. I was a bit worried about this only.
No, ma'am, you can. It will play. You just go there. Don't. That is the next button which you have.
Sorry, is it?
Don't go there.
Don't go once again to back once more. Yeah. That is the next
This
button.
is the play, no?
No, this is next
You are
button.
You are putting next
That
button.
is the that is the pause and play button, the first one. Yeah, please go full screen. It will work. Yes.
Okay, Dr. Arjun, please help. This is the one you're saying?
Yes.
Yes.
Okay, so I'm so sorry. But now it should play.
Yeah.
Should be.
Correct. This is fine.
Now it is working.
Audio?
Can you hear?
Audio you have to play. Yes.
Coming.
पूजा चलो 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 सिर्फ पेशेंट अंदर जाएगा आप बाहर से चलो
क्या नाम है?
पूजा
क्या प्रॉब्लम है पूजा? क्या प्रॉब्लम है पूजा?
पीरियड डिले हुआ
कितने दिन का डिले? पूजा, कितने दिन का डिले है? ये तुम कुछ बोलोगी भी, बाकी पेशेंट्स भी है।
Can I come in?
या
अरे वाह डॉक्टर, काफी फ्रेश लग रहे हो। आपका फोन बज रहा है।
हाँ, एक्चुअली मैं पेशेंट के साथ होता हूँ तो फोन आंसर नहीं करता, पर MS सर का कॉल है। क्या सर? हाँ सॉरी, मैं पेशेंट के साथ।
पानी चाहिए? और चाहिए? तुम्हारा नाम क्या है? पूजा। पूरा नाम? पूजा शिंदे। उम्र? 21। देखो पूजा, डरो मत, बिना हिचकिचाहट बोलो, नहीं तो हम तुम्हारी हेल्प कैसे कर पाएंगे। तुम्हारी उम्र क्या है? 19। अकेली आई हो? नहीं, वो बिल्डिंग फ्रेंड के साथ आई हूँ। बताओ यहाँ पर हॉस्पिटल में क्यों आई हो? पीरियड डिले हुआ था। घर पर किसी को पता है? नहीं नहीं, घर पर किसी को नहीं पता। कितने दिन का डिले है? 26 दिन का। ओके। और घर पे टेस्ट भी किया था, प्रेगनेंसी टेस्ट। Don't worry, everything will be all right. हम तुम्हें इस हॉस्पिटल में सारी हेल्प करेंगे, लेकिन अगर तुम डॉक्टर को डिटेल्स ही नहीं बताओगी तो फिर हम तुम्हें सही ट्रीटमेंट कैसे दे पाएंगे। चलो आंसू पूछ।
सॉरी मेजर, आपसे कुछ कहना चाहते थे।
हाँ डॉक्टर। पूजा, आप वहां जाकर डॉक्टर का वेट करो। सिस्टर।
इस उम्र में बाहर जाके सब कुछ कर लेती है, लेकिन हॉस्पिटल में आके कुछ नहीं बोली। नो कोऑपरेशन एट ऑल।
ऐसा नहीं है डॉक्टर रोहित, ऐसे यंग लड़कियों को रिप्रोडक्टिव और सेक्सुअल हेल्थ सर्विसेज की जरूरत होती है।
हाँ, लेकिन अगर पेशेंट डॉक्टर को कुछ बताएंगे ही नहीं तो डॉक्टर हेल्प कैसे करेंगे?
थोड़ा इमोशनल सपोर्ट देना पड़ता है, थोड़ा रैपो बिल्डअप करना पड़ेगा।
क्या मैटर, इतने सारे पेशेंट्स की भीड़ में रैपो कैसे बिल्डते हैं?
मैं मानती हूँ डॉक्टर रोहित कि पेशेंट्स बहुत होते हैं, लेकिन अगर हम उन्हें कॉन्फिडेंस दें तो वो बिना हिचकिचाहट के हमें सब कुछ बता देंगे और इसमें ज्यादा समय भी नहीं लगेगा। मैंने देखा है कि जब हम मेडिकल सपोर्ट के साथ साथ अगर पेशेंट्स को इमोशनल सपोर्ट भी देंगे तो काफी फर्क पड़ता है पेशेंट्स। 25 साल से मैं इस हॉस्पिटल में काम कर रही हूँ और मैंने ये बात ऑब्जर्व की है। वैसे पूजा ने मुझे सारी डिटेल्स बता दी है, आपसे भी बात करने के लिए बिल्कुल रेडी है।
कुछ बता दिया?
बिल्कुल।
कैसे?
डॉक्टर रोहित, वी ऑल हैव बीन यंग वंस, और जब हम यंग होते हैं तो ऐसे सिचुएशन से गुजरते हैं, और जब ऐसा कुछ होता है तो डर तो लगता ही है। वैसे पूजा ने काफी हिम्मत दिखाई है ना?
वो तो है।
चलिए डॉक्टर रोहित, आपकी पेशेंट आपका इंतजार कर रही है। अच्छा, पिछले हफ्ते दिलासा का वर्कशॉप हुआ, वो आपने अटेंड नहीं किया राइट?
हाँ, मैं
उसके हर वर्कशॉप में मैंने कुछ ना कुछ जरूर सीखा है। अब कुछ ही दिनों में उनका अगला वर्कशॉप होने वाला है, तो साथ में चलते हैं।
जरूर।
Good afternoon, everybody. Hello, friends. I'm here to talk about comprehensive healthcare response to the survivors of violence. Now, what is Dilasa? Dilasa means reassurance. Emotional support is the first thing what we have to give her. Whatever she's saying, we are listening to her, she's going to open up. Nowadays, we are receiving so many young girls and adolescents who seek information about sexual and reproductive health services. What do you think? How can we help them? Can anybody answer this? Yeah.
I think we should recognize that they have faced a big challenge in coming to us, and we should provide them with medical treatment, but also psychosocial support.
This is absolutely right. Adolescents are facing so much of problem of stigmatization of unwed mothers. And if we also don't give them any help, then they have no place to go. Then to go to quacks and do some different types of abortions, and which again have so many complications. When they come to us for the first time, we have to assure them and give them the help needed.
NASA is a very ambitious project of Mumbai Mahanagarpalika with the support from
I'm just going to stop here.
In higher education is amazing. Thousands of copies have been sold
I'm just trying
across
to
the United States and the
stop
world. You can pick up your copy today on Amazon. Welcome back, everybody. It's your time to add up on the
I'm
Edip
so
Experience
sorry, I'm trying
podcast,
to
where we make
shut this
education
off.
your business. Dr. Joe Solucio back here. And you have not yet picked up our book that we wrote this
Arjun, have
past
I
year
again
called
done
Commencement,
something
the
wrong?
beginning of a new
No,
era.
ma'am, you can go again to that.
I
stopped
that
sharing
because
screen.
the first 120 college and
The
university
browser has still that on.
podcast.
Go to your
Ask
browser.
all the same question. What do you see for
Okay.
the future of higher education?
I'm
We
so
took
sorry,
all of their
these
answers
technical
and the
glitches.
trends and issues that they
Okay, I'm
and
just
we
going
put
to
it into a
exit. I
book,
think that's
which we
easy, and
know
I'll
you'll love
rejoin.
if you love
No,
higher.
ma'am, you don't have to exit.
Set
Just
up,
go to
it's
your
available
browser.
on Amazon, of
Minimize
course.
it.
Because this is just
You'll see me.
Okay. But then it will keep on playing, nevertheless. Because I think we can continue with the Q&A round after Vibhuti ma'am's session.
Yeah, yes, sir.
Let us go ahead. Sure.
Vibhuti ma'am, you can continue with your remarks and your session as well. Ma'am, you are on mute. Ma'am, can you unmute?
Yeah. I think Sangeeta's presentation is extremely important. The way the whole project on gender in medical education has taken over, and now the response that they are getting from the medical fraternity, the biases inherent in internalized biases that we have, I think they have been countered. And with that, how the approach of the people, medical fraternity also changes. And Dilasa is not only interacting only with the doctors, but also with the medical administrators and the other staff. And I think it has also played a pivotal role in contributing to the new act we have, Protection of Women from Domestic Violence Act, where 5 service providers have a clear-cut role to play. So I think that whole action research part of Dilasa was very important, and also the training. So I think these are the takeaways. And now I think I'll make a small presentation on social determinants of healthcare and gender equity. But I think more of everything, most of it is covered. But I would just like to one is that as Sangeeta and even Dr. Naik also talked about how the structures and systems that determine gender equality, so many examples were given, and there are so many training modules have also been created, and how with the change in the attitude, gender relations and the gender stereotypes, even the policies also change. And there are several examples with Sangeeta also gave of the work of Sehat, and the whole question of intersectionality, that how intersectionalities of your vulnerabilities or the class and caste and ethnicity, your location, where are you, and what kind of accessibility you have, that plays a very important role. So the socio-economic and political factors also, because to what extent the state takes attitude, the women's question, whether it is seen only within the framework of reproductive and child health, then if that is the case, then you would not give weightage to the those who are in the 0 to 14 age group, because they are not in the reproductive age, and even the elderly women, they will be left out, or the elderly people will be left out. So I think it is very important to understand and why we need to transcend biomedical approach. So the living condition, working condition, public services, the kind of infrastructure that you have, and also the individual's behavior, that they are determined by the patriarchal way of thinking and the patriarchal system, value system, that play very important role. The question of age also plays a very important, vulnerability of children, the young adults vis-a-vis those who are in the middle age, or also the question vulnerability of elderly people is of a very, very different type. Even when we talk about the senior citizens, elderly women have a very different kind of a predicament than elderly men. So the question of that when we start, it is the gender unequal. I think Dr. Naik also said that what kind of gender inequality that we are facing. And then that makes you gender blind is a very objectionable term. Disability movement has taken objection against it. They call it gender absent. And that when you have a gender absent approach, that also leaves out so many people, and the whole focus is on men. Third level is that of a gender sensitization, which is now it has become a big thing, and now gender sensitization has been happening. So you take into consideration gender norms, roles, relations, and then you also come up with a gender-specific intervention strategies. And then you have a gender transformative. Once you intervene, your thinking, your policies, your implementation, your budgetary allocation, your way of dealing micro, meso, and macro reality changes, and then you have a gender transformative transformation that is taking place, because you have taken into consideration not only the practical gender needs, but also the strategic gender needs, which completely changes the power equation. And what we saw during the pandemic specific, we are going to have a special session on pandemic, but we saw that all those who were saying that virus doesn't discriminate between people, we all know that how virus discriminated between different people. What happened to children? What happened to girl child? What happened to women in reproductive age group? What happened to women not being allowed to be born with the abuse of of the sex selection technologies, because even PCP and DT Act was freezed. So I think it is very important to take into consideration the systemic issues, structural issues, and the institutional framework that when we come up with the health policy. I think it was a major mistake not to consider reproductive health concerns and the child rights concerns as an emergency, because you just can't say that corona is the only emergency. All other things are not essential. In the essential service, all these things should have been taken care of, even in the midst of a massive attack of coronavirus. So I think these are the learnings that we have. Another thing is that when we talk about the model of how do we deal with the disabilities, okay? So there also we see that gender plays a very important role. The whole ideology of ability or a superscript model, always you would show the person with disability, how they are, some of them who are becoming the they are the heroes. And then you expect the same level of performance from other people with disability. I think that is also wrong. Then the question of the textually mediated method we teach in terms of for teaching or training, that also creates its own limitations. The whole the medical model and the social model, both of them have to converge, because medical model is only of treating people clinically. But what about the society in which the person with disability is negotiating various day-to-day transactions, the lived experiences of person with disability, their life works? It's very important for the medical professionals to be aware of it, and also create a very empathetic environment. That showed us that the moment there is empathy, whole equation changes. So the question of person with disability having role-lessness, and I think that role-lessness, even the transgender community have also said that when any girl or my papa kehta hai bada naam karega, or my daughter will be like this, that kind some role, even within the gender stereotype, roles are given to quote unquote normal people. But what happens to person with disability? What happens to person who is intersex? They are abandoned by their own people. When with disability, as one woman in a conference, she said that I'm treated as a piece of furniture. I am not treated as a human being. Okay, the way you and you have all other things in the house, she's also there. But She is a part of the family, and all other things which other members are doing, she also has a right to do. That kind of approach you don't see even within the family. What kind of entitlements they have, and right to education, right to dignity, right to dream about what they want to do in the future. The question of sexuality, that is also now being discussed by persons with disability, and also the question of value-based uniqueness, that we can't say that some person, we are so-called able-bodied, and they are disabled. Everyone has a value-based uniqueness. Someone is good in verbal articulation, someone is good in drawing, someone is good in maintaining human relations. So all those values are extremely unique. So you just can't club some people who have a physical or disability as a people who are of no worth, no. So they are worthless. That also comes out. And the critical disability theory, now it has become very important, and people are debating. I think that also has to be taken to the medical profession. The ecosystem theory, under what socio-economic environment that the person is negotiating the skill. Whenever there is a more enabling environment, you see that everybody flourished. Imagine a country like Vietnam in 1975, when it became independent from the American imperialism. They had country had to face 40% of people who were made disabled because of the constant bombing of the country by, and that too a napalm bomb, which was extremely destructive, because all the particles entered into your body and then they burst. So you can imagine the kind of pain the population had to go. And how do you organize your society with people who have one hand or one leg or one eye is gone, or a part of the face has been scarred? So it is very important to see the question of disability, contextualize it in the socio-economic, cultural, and political context. And now we have a technology, how to make technology accessible, how to humanize technology, how to make the equipments which are friendly, gender friendly. You just can't keep a man as a unit of analysis when you are come up with the technologies, and also the supportive efforts of the society, of the community, of the educational institution, of the medical fraternity, extremely important. I think these are the issues being discussed. And the challenges that we are seeing in terms of a gender responsive approaches is that the acceptance of power relations and the structural forms of gender inequality, we starkly concentrate the disadvantage against the girls. I think Dr. Professor Naik gave us so many examples of that, or a women, or a transgender persons, or the person with disability. I think there are these are the very important 7 approaches which have been debated. First approach is to transform and deepen the normative framework, and you saw in practice how the Sehat is doing it. Whole presentation of Sangeeta is mainly talking about that. Even the intervention strategies about which Madam, our first speaker, Madam spoke, I think that is also very important. Second one is the create, implement, and enforce formal international and regional agreements that we have, the UN code, WHO's directives. I think it is very important because a lot of work has gone into it, and we can come up with so many innovative programs based on the principles which have guidelines given by WHO. Third one is that the question of gender exposures. Wherever there are good practices happening, why can't we amplify the voices of them, those practices, and also replicate these models? So that is a very important this thing. When the question of dealing with, say, drug abuse, or dealing with the high risk behavior, the adolescent crimes which are increasing, what kind of methods can the healthcare systems, while providing the support to the survivors, can also come up with the education, how we, in the film, how they change the attitude of doctor, okay, by the intervention. That is very important. Also, along with the provision of the essential health care, we can also deal, it is not only the doctors and officers in the healthcare industry, but also the other healthcare providers like auxiliary forces, volunteers, technicians, informal care givers. All of them, we bring them into our discussion, and also our decision making is very important. And there was a question, I think, about the mental health. And I think in the mental health also, biomedical approach has not provided any solution. It is the involvement of the community, involvement of the family, and involvement of the counselor, all three of them, when they converge and discuss democratically, then we are able to provide effective care. Another thing, that collection of data, disaggregated data, is very important. There was a question about the NSS data on the health-seeking behavior. There are so many micro studies with the public health scholars and the organizations like Sehat have done. So it is very important to understand that what kind of needs are there and what kind of intervention strategies that we can do, and also what can be the role of women in the health research that can also be brought out. Sixth one is the accountability mechanism, that what kind of accountability we set up in terms of ethical practices. In terms of, recently there is a big debate going on about why so many children in Ethiopia, they died while using the cough syrup of India. So what kind of accountability system do we have to the pharma industry? So far, we haven't heard that any of the pharmaceutical companies which provided, we exported those drugs, they have been brought to book. So that is also very important. Gross violation. If you see a film by Deepa Dhanraj, something like War, you can see what is happening in the vertically imposed population control policy, where women are not even treated as human beings, and the gross violation of their bodily integrity and the dignity takes place. So I think this has also some of the random control trials. There is a whole history. I think Dr. Amarjit Sani's session will highlight that. So, but I think these are the ethical standards and the SOP, standard operative procedures, that we need to come up with. And also the organizing women, and organizing in a circular. You can see the way these women are sitting. They are sitting in a circle. There is nobody is superior. Nobody is having, whether you are a doctor or a nurse or a auxiliary staff or a person, lay person like us. We all have a right to contribute to the collective wisdom. To come up with a very, and we have seen some of the campaigns like of Indian Women's Movement, a campaign against sex selection. Initially, all the scientific terminologies and so many new language of the new reproductive technologies, they were alien to us. But as more and more workshops and discussions and debates started taking place, finally it was when the legislation was formed, they had to take the people who were involved in the movement. They also played a very important role. And Sehat has also filed a public interest litigation in the Supreme Court of India, along with Monsoon in Pune and Dr. Sabut George, about sealing the gaps in the PNDT Act, because and there it was the people's organization. It was the people working with the community and the grassroots organization. They were the ones who provided evidences. So this is the 7-point approach that we have. I have used some of the references. All of them are in public domain and they can be accessed. And there is a query in the chat box whether we can share all the PPT. Definitely, our PPTs can be shared. We can send it to IMPRI, and IMPRI can share it along with. And most of the readings are also included in the dossier which you got today. So that way you have been able to access the best material that we have. Yeah. So now I think we can have Q&A, or we can wrap up the session.
Thank you so much, ma'am, for such an enlightening session. So now there are a few questions, ma'am.
Yeah, is that Sangeeta joined? Has Sangeeta also joined?
Yes, ma'am. She is also, ma'am is also here. Yes, ma'am.
Yeah, okay. Yeah, so she can also, yeah, we can unmute and also.
So Amruta Girishji, you can unmute yourself and ask the question.
Yeah. The first question is by whom? I think the name is not written.
Yeah, actually, ma'am, this question was.
Amruta ji is here. Amruta ji, you can hear us?
Yeah, the one I had put in the last session, right? Yeah, ma'am, I wanted to know how effective the mental health care policy has been, especially for women.
Yeah. Lot of work has happened in the mental health policy. For the first time, community-based mental health organizations, they were involved in it. It has critiqued the earlier policy, which was focusing only on the biomedical approach. They have, in principle, accepted the community-based approach role of the counselor, and also the education and about the mental health, because the stigma and isolation and exclusion that the person who is dubbed as a quote-unquote mentally ill has to face, plus so many institutions where the undemocratic practices are taking place. About that also, the whole iron wall of secrecy around mental hospital, I think that also has to go. Accountability of the mental health institution, that is a very important aspect of it. People's participation, community-based decentralized mental health care services, that is very important. And you can see for the first time last year's budget, union budget, allocated over 700 crore rupees for mental health concerns, and NIMHANS has been allocated. They have been entrusted the responsibility of coming up with the strategies of mental health interventions, creation of a specific helplines, investing in helplines for children in distress, helpline for women survivors of violence, helpline for people who are homeless. So I think those kind of approaches, that you guiding them, what are the support systems available, that is also very important. And also the police helpline, I think that is also that has come, that counseling now in the training programs of criminal justice system, the mental health module on mental health has been introduced, which is very important landmark which we see. But still we have long way to go, because massive training, because earlier in the police academy, in the curriculum was very rigorously taking up gender questions. So I think that has to be to start, because that generation of officers have retired, and now the fresh new officers have come who have been deprived. So I think what SAID is doing for medical colleges, similar thing we need to do even for the criminal justice system, because every time the fitness certificate has to come from the criminal justice system if a person is in the mental asylum. No, so that's very important. The massive gender sensitization training is required, because every case, like earlier, I remember when I was a full-timer of a center that provided institutional support to women survivors of violence, every time a survivor of a violence was brought to us by her in-laws as a mentally ill person. Actually, there was nothing wrong with her. It was the harassment by the spouse or the in-laws that had created withdrawal syndrome or the depression or this thing. No? So we need to even sensitize the people about the mental health issues to the all service providers. Yeah. That's there in the mental health act. Sangeeta, would you like to say something? Hello?
Vibhuti, you've covered everything, so I don't have to add, but just to say that, as you know, while things are moving, the allocation to the district mental health program is not uniform across different states, and that's the problem that we foresee.
Is it because proposals are not sent? Because see, the money will come, you have to send the proposal, no? So are there any districts who have not, because
not really. I mean, it's also about appointment of staff from the National Health Mission to the district mental health program.
Correct.
And that's not happening. So for example, we do have very good pockets of innovations. There is a very interesting project called Atmiyata that is working in Gujarat, but that's really about the state of Gujarat implementing it across the breadth of the districts. But that's the kind of allocation that the state needs to do, because the NGO in that sense has a limited capacity to scale something up. So
I think other questions are directed to Sangeeta only. Sangeeta, you can keep your video on and answer. Roshni Babu, would you like to speak? Hello, you have asked the question. Yeah.
I'm just
yes, please.
Yeah, please go ahead. Please go ahead.
Sangeeta, do you want to read it or do you want me to ask the question?
It would be just easy if you can ask me the question.
Certainly. So what I've noticed is in social media, there are a whole lot of influencers posting videos where they're questioning how trans women are entering sporting events with the women's team and acing them and winning all the accolades, right? Now, I was just wondering, how is this fair to women, cis women? right? And also, what is the criteria to categorize someone as a trans man or woman? Because we are talking about biology here, right? We're talking about sex, we're talking about hormones, because of which the sporting power of an individual is enhanced because of the hormones, etc. So how do we, as gender allies and allies of gender equity, view this and address it? I am a bit confused at this point.
Yeah, so Roshni, like you said, there are no straightforward answers to it, but there is no conclusive medical evidence that could segregate biologically men and biologically women. Though the forensic science has progressed to a significant extent, I think the entire discipline and, how does one do sex verification, whether it is ethical, because just the preponderance of a certain hormone can't really determine that I am more a man than a woman. And that is something that is being challenged in the domain of medical ethics. If you see, and I can circulate this to our colleagues at the IMPRI, there are international guidelines that have now been positioned to say that how does one do an ethical decision making as far as people who are trans are concerned, or those who are intersex are concerned. Because what is the vantage point that we are talking about? Is it about being physically sturdy? For example, there are two case studies in the Indian context. You may remember a very famous player, who won a medal. And
Yes.
later there was another, I think there was a sex verification test indicating that she was a male. She ended up becoming a laborer in Karnataka, completely rid of her medals and so on. And that was when I think the ICHRL or somebody actually took up the case on what is the ethics of this profession, and what is the scientificity of these tests. So while there are no straightforward answers, just the negative implications on people who do not, in a sense, physiologically conform to the XX and the XY. And like I said, that there is no specific hormone that will then clearly and eventually determine, because the levels would be different, no? That can't give somebody the right to say that I am actually masculine just because I have a preponderance of a certain hormone, and so I should not be contesting in the women's group. But it is a contested issue. There is global evidence available, and like I said, that I think Professor Vaswani may also allude to this in her discussion at a later stage, because it's a forensic expert.
There is a question by Mr. John. Can you ask? Hello?
Hi.
Aquilin John? Yeah.
Yes, ma'am.
Okay, you are a woman.
I think the athlete that ma'am was talking about was Shishanti, who won the I think silver or bronze medal at one of the events. So I specifically had a question about pain, and specifically chronic pain related to conditions that a lot of gender minorities bear. There's very often little to no room given in terms of pain alleviation or support that is extended for understanding or alleviating pain. I was just wondering if maybe I don't know anything about it and there has been some work done, or if there is any work that has been done towards understanding where pain should be accounted for in both policy as well as, healthcare services with respect to gender minorities.
Yeah, so I can try take a shot on this. The way biomedicine looks at pain in itself has been critiqued largely. There is often a sense about pain threshold that, like I said, comes from a middle-aged, middleweight male, and then that's extrapolated to different people. There is some work done on race. There is hardly any work done on access to pain relief for gender minorities. But there is significant amount of Western medical literature that talks about how is it that Afro-Americans have been kept away from pain reduction medication just because of the belief that, they have a better pain threshold. So, it can simply be extrapolated even to the Indian context in different ways. And also, I think while at Sehat, we've not done a study like this, I feel that it's the perceptions that override the medical decision on pain relief. And, happy to kind of have another discussion on this at some point, but, there's little or no work that at least I know of. But you may want to go to the Sangat website, where they have an entire project which is called the Trans Care. And that's looking at different research, also how to do sensitive research with the trans community. And, they may be able to help with some of the research questions around what is being done as far as pain relief for trans people is concerned. I'm talking specifically about trans. Gender minorities can fall under a whole different dimension.
Thank you, ma'am. And any thing in terms of looking at pain within the ambit of disability or an invisible disability, is there anything that you can speak to about that?
Similar issues, all of these, I would say, are neglected issues in the biomedical practice. For example, people with either physical or psychosocial disabilities and pain. And, how does one understand and document their pain? And, what is it that we are offering as pain relief? So I would say there's very little Indian literature. And if you are interested in research or you're a researcher, I would strongly request that let there be a dialogue on actually documenting from a user perspective about access to pain relief. And also, how is it that the typical medical professional looks at pain? There is a lot of literature around cis women, around heterosexual women, and the entire reductionist approach of the biomedicine to relegate pain to something which is just, in their heads, in their minds. So you will see a lot of work around, women in labor and in labor studies, and the fact that, pain is not something that is considered. In fact, it is trivialized.
They call it psychosomatic. Most of
Exactly.
the time it's called
Exactly.
psychosomatic.
But
And
that's
other thing, Satyashri Goswami is to study. She has just submitted a thesis on pain. Yeah, based on a qualitative research. I think it will be in public domain in 3-4 months because
Okay.
it will be there on the Show the Ganga. Because a PhD thesis, all PhD dissertation after Viva are put in public domain. Yeah.
Ma'am, can I email you about this? Would you be able to send me? I didn't quite catch what it was.
Yeah, Satyashri Goswami. Yes.
Okay.
Yeah, definitely.
Yeah.
Now, Sasha Nizar, Sasha Nizra, would you like to ask your question?
Yes, ma'am. Firstly, thank you to Poonam ma'am, Ms. Sangeeta, and Professor Vibhuti Patel ma'am for the great sessions. I quickly wanted to first introduce myself very shortly that I specifically work in communications for social impact organizations. So I represent people who are talking about gender minorities, who are talking about LGBTQ community, mental health access to rural communities, all of that. So as a person who is also educating herself on the go, all of these things, are there any resource materials that we can refer to? One of the resource material my organization has also built up, but are there any other resource material that makes us more culturally sensitive? For example, gender minorities is a great term to ensure that everybody feels included, yet they don't feel offended. So are there any other resource materials, specifically in Indian literature, maybe that we can use as professionals and also as students to gain more knowledge as to how we can be more inclusive in terms of our language as well?
We can send a host of those resources across to the team, and I'm sure they can email it to participants.
That would be great, ma'am. Thank you.
I have written the name of organization, its website, and the transcare, what she...
Yeah, Sangat.
Sangat, yeah.
There are about 3-4 that actually Dr. Aksa Sheikh has, but she is going to do a session, so she will
session
be able to direct everybody to a host of resources.
She has started a WhatsApp group
Yeah.
for doctors who, it is a Twitter group also, and it's a WhatsApp group for all the health professionals who are sensitive to trans care, no? I think.
Yeah.
So ma'am, there's one more question from Dr. Shruti Sharma.
Doctors for Trans Folks. That is the WhatsApp group she has started. And she has also started a Twitter group where all the medical health sensitive people, it's not only for doctors and all health providers, that group. And it's a very fantastic, the kind of responses you are getting, very sensitive responses on this WhatsApp group they are getting. It is the group is expanding now. Yeah. We have a special session by her, Dr. Aksa. Yeah. Questions? Yeah.
Dr. Shruti Sharma, you can
respond, to Dr. Shruti's question. This is again an issue that will, I think, be dealt in the next session. But just to say that, financial independence and decision making, financial independence may offer a slightly better privilege than the ones who don't have financial independence. But often research studies and our own work has indicated that even if you're financially independent, the control of the finance, if it's in somebody else's hand, within the family, then it really does not work. And especially with survivors of domestic violence, this is something that has been found, that financial independence can offer you an edge, but also, if women are trained to actually implement their autonomy, have a say in decision making, something to do with empowerment training, to be able to say that I am going to be saving 30% of my income. I cannot be handing over my full income for the family. Those are the kinds of assertiveness training. If we can offer women along with financial independence, then I would say that that would be one way of actually going about it. And out of pocket, I would say, is an issue across the country, not just for, financially dependent women. It is there for financially independent women. We all know in COVID, even the working class has been pushed disproportionately into poverty. So these are the implications that we are actually seeing of out-of-pocket expense, and with the growing privatization of the health sector.
There is a question by Shruti Sharma.
Thank you for your answer, ma'am. Ma'am just answered my question. Thank you so much, ma'am.
About the child rearing, there is a question about.
Ma'am, the next question is from Tripti Sinaji. Ma'am, you can, Tripti Sinaji, you can unmute and ask your question.
Good evening, madam. It's been a very interesting session, especially we are now freely talking about the transgender community and how to make them more inclusive. But my question is basically on the more traditional problems that we face. How can we sensitize boys, either in school or out of school, who are going to be the future men in the society, to change their perception about gender roles? Because that's when they start having biases to it. So how should we go about handling adolescent? We talk a lot about adolescent girls, but I think we need to handle the adolescent boys also. They can also contribute a lot to the health of the women.
Vibhuti, can you answer the question?
Yeah, I think the question, what is it? Because I was, okay. How can we sensitize boys to change their perception about? I think it has to happen at a very early age. Because what we are doing in WDC, where their ideas are already formed. So I think early childhood education is extremely important, and right from the textbooks in which how the roles are depicted for girls and for boys, that is one. In the family, because now the women's movement is saying that instead of telling women how to dress and how to not to go out, why don't you train your boys to be respectful of girls and respectful of, because some of the shocking things that have happened during pandemic also, boys locker room, even in the pre-pandemic period we had from the international school in Mumbai, no? So I think if this is the kind of values which boys are getting, And the cheapest literature is pornographic literature. My problem with pornography is more on because it valorizes and escalates violence against women and girls, because it also valorizes the sadomasochist relation. Man is a sadist and a woman is a masochist. No, she likes to suffer. Or a man is a hunter and woman is a prey. That is the kind of ideology which is valorized by that. So I think against that, we need to create a very, very important, different kind of value system. And education begins right from the family. Even in the PTA meeting, we need to discuss this issue, at least because of the POCSO protection of children from sexual offense ordinance. At least now in the PTA meeting, except for Bollywood songs and nice food, they are now started discussing serious concerns because it is mandatory by the law. So I think it is very important to have both from the family, from the community, kinship network, everywhere the sensitization is required, and the education system can play a very, very important role in changing. In fact, all those women who provided support to Bhavri Devi after she was gang raped, this was they had a massive burnout. Imagine she was raped in 93, the judgment came in 97. 4 years of support work to Bhavri Devi, and under extremely hostile, misogynist environment. There's a whole group called Mahila Samooh. They decided to go to Himalayas, and they took their sleeping bag and they were in Himalayas for nearly 6 weeks. And they said that in none of the Himalayan valley, wherever they were staying, camping at night, nature was harsh, food was scarce, but there was no violence against women, or they did not hear any bad word against women and girls. That means that all this is not innate. It is the acculturation, and we have internalized these values through the social norms and society and the kind of misogyny that we are seeing. In fact, all the studies, recent studies also show that all the adolescent boys and girls with whom you, after like counseling and after discussion with the social workers, they said that we got attention from you only after we got such harsh punishment. We are in jail. I wish you had met us earlier, because we grew up and seeing my father raping my mother every night. I would hear the scream, and all the bad words that we heard all around, all the galis, all the abusive words were targeting women's private part. If this is the culture in which I show, and I realize that it's a power relation, either you win or you lose. So we see human relation as a zero-sum game. So we also started using the same thing, because who symbolize power? One who is cruel, one who is using misogynist language, and one who is conquering. They call it conquering, no? Sexually overpowering a woman. So if this is the kind of education they get, so I think our role becomes very important in changing that kind of a culture. And I think when in the PTA meeting, these issues should be discussed very seriously. Even in the community-based meetings, we are talking about water and electricity and needs of the people and transport and infrastructure. The focus of the community-based organizations is mostly on the day-to-day livelihood issues. They are important, very, very important, but at the same time, issues of gender norms and how to change the gender stereotypes and make the human relation based on the foundation of equality, mutual respect, care, and concern by every individual. I think that is the kind of work we'll have to do to change the kind of internalized values and the misogyny and the patriarchy and the hyper masculinity that our children, boys, are internalizing. Yeah, thank you. I think I'm really very happy with today's interactive session and the engagement of all the participants. I think Roshni Babu, your question is, do you want to ask your question? Hello? About IVF? Hello?
She has a incident to share, I guess. Roshni Babu.
Yeah. Recently, there was a study that was published, that said that many women who are going through IVF therapy and where their oocytes were being extracted were complaining constantly about pain, but none of the doctors listened to them. After about 3 to 4 months, they got to know that the pain medications in the hospitals were being tampered with by a nurse and being replaced by saline.
Oh my God.
And that is when the doctors realized that all these women were actually complaining about pain, and none of them bothered to check why all these women are complaining about pain. Now, this is the attitude that we need to counter. We need to combat this one. And when a woman is saying something, at least it needs to be acknowledged and acted upon.
Yeah, I think here there are two questions: internalized misogyny and cruelty. They are combined together. So I think that you need also the punishment to that nurse, no, who did this. So I think it's you just can't take it lightly. There has to be accountability system. All of us have internalized misogyny and certain biases and no sensitivity. And that's why if you read the Sehat study on violence in the maternity ward, when
Yes.
women are in labor pain, what the doctors and nurses do, what kind of abusive language they use, and some of them are beaten up also. So I
They
think
slap, yes.
they slap also. So one is a cruelty, and second one is a internalized misogyny. They would not do such thing to a male patient. They won't.
Never, never.
Why would they do it to a woman who is in pain and who is in the birth? So I think these two both and I think there has to be accountability and there has to be punishment to the person who does such things. No, yeah,
true.
So the medical, even the law has to intervene. Criminal justice system has to intervene. I think in so many countries they have it also. Yeah.
I wanted to add a point there also because, pain symptoms in females, they are more related to the psychosomatic aspect.
That's what doctors say. That's what doctors say.
It's functional. And I think that is also more the reason, why not due care is given to such symptoms in females.
Yeah.
I would like to differ on that actually. I would like to differ very much on that because whenever the pain, in fact, it's underestimated. Even if you go to OPD for the antenatal clinic, we have our seniors who taught us even before that don't give more time. If they say pain in the hands, feet and all, just think Hatha Pava syndrome, give B complex and send them back. They are not adequately, the symptoms are not addressed adequately. It's just a cursory glance and give them multivitamin and send them off. So you're not treating them really systematically.
Yeah.
In fact, for that matter, I may be covering in my presentation, there's a neurosurgeon who constantly complained of pain in the head and she wanted a CT. And then her colleagues laughed her off. After 2.5 years, the NHS allowed her to do the CT scan and she had a grade 3 tumor. And she's a neurosurgeon herself.
Correct.
So many times we do think their symptoms to be very trivial.
Correct.
But like pain has different components, it's worthwhile knowing whether she is very stressed because of the relations, intermarital relations, anxiety because of so much responsibility given. But I wouldn't justify it as a psychosomatic though.
Correct. No, and
It would
even
be a bit
women who are taking hormonal drugs for the contraception or those who had IUD inserted.
Yes.
I have heard in doctors calling it psychosomatic pain. Imagine they are getting yellow discharge, they are getting foul smell, they are getting uterine contraction, and you call it psychosomatic, and not. I think it's a very much.
In the same vein, postpartum depression, what we call it as now, was termed as hysteria.
Correct.
In medical history. They did not even consider that to be investigated and worthy of being treated in women. It is just given as, the craziness that women go through after birth.
Correct. Yeah, you are right. I think we should read a history of witchcraft also, witch killing. From 13th century to 18th century. A lot has been written by the historian, how the traditional healers who were more accessible to women who face different kind of problems, they were witch hunted by the priest because they were the ones who were practicing, earlier the patriarchs who killed these witches who were providing, they were the healers, traditional healers, and how modern medical science witch hunted them, that is also a strong misogynist bias that you see in the history of medicine. Aquilin John, would you like to ask your question? You have raised hand.
Yes, ma'am. Ma'am, I appreciate all the discourse that's been happening around pain and all of that. I just wanted to add one thing, which is that I'm studying psychology now, and I just recently was looking at what constitutes clinically the term psychosocial or psychosomatic pain, and how that is considered a diagnostic valid diagnosis for pain conditions across the world, not just in India. And it's very interesting because the more you read into the verbiage of how it is and how it was initially prescribed to be, noted as a pain condition, a huge burden is placed on the medical practitioner to completely rule out every other possible medication. Given, reasonably given whatever the psychosocial resources are available at that time. And in a country like India, that is where diagnostics for basic things don't happen. Exhausting everything else seems like a very long, it seems like a dream almost. It's never going to happen. And until that, it seems like pain conditions will be ignored to an extent where it will always be ignored. And it seems like a very sad thing to me. I mean, it was not really a question.
No,
I
but see,
think
the self-help groups, all those who have created self-help groups, the people with a similar kind of pains, if they come together, they talk about it, they come up with the various therapies also. If you see, only stick to biomedical method, then of course it's a dream, it won't happen. But there are so many other methods of healing, and especially the mutual counseling, sharing of knowledge of dealing with the pain, various types of therapies you have, whether it's a song therapy or dialogue therapy or therapy of fragrance therapy or massage therapy. There are various things which have been tried. You can see customary practices, to deal with the pain, or even palliative care. Suppose pain doesn't get removed, you have a cancer or this, but still the palliative care, pain management, which is so important, where the community, when community is involved, it is easy to manage pain. So I think that is very important, and which the medical science has to acknowledge that these are the very important. We know of so many super specialists taking, say, homeopathy medicine. Why? Because they talk, homeopathy doctor, they talk to you. They ask you, they go into your whole history of 50 minutes of history they take. And so many hidden things which you're not even, they were there in your subconscious, they come out. And then the kind of relief that they face, they get. So I think we need a pluralism, and we need a far more plural way of dealing with pain. Yeah.
Yes.
Yeah. So now I think we have summed up that today's was an extremely engaging session. It was a very very what you call energizing also, because now we have 3 more days to go. But after today's experience, we feel that it's going to be really a very rewarding sessions. All the sessions with such a great engagement of the participants and the kind of serious questions that we have been discussed after each and every presentation. So we have exceeded the time limit, but I think it was worth it. Over to Fiza.
Ma'am, actually, Khushbu Datta ji also have something to add before.
Okay. Yeah. Please go ahead. Yeah.
Hello.
Yeah.
Yeah. There was mass hysterectomy was also evident. There was hormonal imbalances due to this. There was a probe committee which investigated numerous cases of hysterectomy found largely amongst sugarcane migrant laborers, specifically in the Beed district of Marathwada and elsewhere as well. This is case of lack of knowledge, but it is also evident in cities as well. What could be the reason, or what could be the solution to these kind of medical negligence?
Vibhuti, should I answer it?
Yes, yeah.
See, our own work has shown that, in case of any kind of excessive bleeding, and once a woman is about 24 and onwards, most gynecologists understand that her reproductive curve is done and dusted. For example, if she's completed her childbearing thing, then the immediate solution to excessive bleeding, pain, cramps, and so on has been, unfortunately, hysterectomies. And now you know that there are different forms in which hysterectomies can be done. They will save the uterus, they may save the ovaries, this, that, and the other. The challenge is about getting gynecologists to think of alternative ways of managing bleeding, managing pain, and managing everything else. So this entire approach has been seen as a very biomedical approach. Ideally, a hysterectomy should be the last resort, but it's often the first resort because the decision maker often as an expert is a doctor. And that is something that we are seeing. In fact, even in children and adolescents with psychosocial disability, especially when caregivers come upfront and say that they're finding it difficult to manage menstruation in women and girls with psychosocial disability, pat comes the response ki get a hysterectomy done. So I think there needs to be a movement really to be able to explain the horrendous side effects of this unwarranted hysterectomies, and we need more education, and medical, what do you say, like pushing the field ahead to think of alternatives to hysterectomy, because there are. But this constant medical management of, thinking that now the uterus has done its job, so you just remove it, is really not the way forward. And I think that, it's not as much a technical answer as much as the need for gynecologists associations to come together and say, we will not do this because this is not clinically indicated in all cases.
Just take up the Sangeeta, also the issue of sugarcane workers post hysterectomy. Aquilin has asked this question.
Sorry, ma'am, not a question, just
yeah, exactly.
But what you have written,
of the study, so
what you have written is problematic because it is not the question of only hygiene and this thing. Women did it unconditionally. The employer, sugarcane factory workers, they said that we don't want this janjat, we don't want this headache of 5 days of menstruation and also the women getting pregnant and the childbirth. We don't want this headache. We want you to work 24/7. That is why they were given this. Another thing is also today that we had a meeting on working women's charter, where so many grassroots level workers and trade unions also said that women in garment industry, export processing zones, all of them are given contraceptive, emergency contraceptives to postpone their menstruation for meeting the production target. So I think it is, you can't say, it may be the externality that because
Yes,
now for 5 days you will not have to clean. You don't have enough water to clean and all, but that is externality. But main thing is that post-sexual violence and history.
Yes,
And
ma'am.
imagine at the age of 22, 23, I have made those, TISS had organized a workshop of the trade union leaders and all. And they said even 23, 25, 27-year-old women, they have been hysterectomized. No?
Yes.
Just because the choice is between hunger and work. And you will get work only if you have a jodi. Then single woman can't get work. She has to have a jodi, man and woman, both of them. So, and if you want to become a jodidar, you want to be the couple, then you have to get hysterectomized. That is the conditionality which the employers, sugarcane workers, to enhance their productivity, because they are exporting sugar and they have imposed it on them. No, so it is
Yes,
not.
ma'am.
They have not done
Absolutely.
it.
Dr. Patel, I'm also wondering if there is, environmental factor in most of the women working in the sugarcane field having this condition, because excessive use of fertilizers can cause so many different illnesses. And, there is evidence that excessive use of fertilizers is affecting our sexual hormones.
Yeah.
So I was just wondering, and
But
why
force them to have hysterectomies? No,
totally
here
understand.
the question is a very different issue. Other is occupational health hazard that also we have to deal with.
We have to,
That
yeah,
is a
we have
different-
to
But
explore
at the
that
same
one.
time,
And
you can't force any person to,
no,
as a
not at all.
conditionality for
Definitely
a
not.
job to have hysterectomy.
Yeah,
Yeah.
definitely not. Yeah.
Yeah. Thank you, Sangeeta. I understand. Okay. Yeah, we can be. And now I think we can close the session also. Yeah. But I think we had a very rich discussion, so many issues regarding, and this is far more convincing that there are social determinants and we need to go beyond biomedical approach and understand the social determinants of healthcare system as well as the healthcare services and the predicament of the those who face intersectional gender vulnerabilities. Yeah.
Thank you so much, ma'am.
Yeah. Thank you.
Thank you, ma'am.
Yeah.
Thank you so much, ma'am.
Yeah.
So, as we have come to the end of day 1 of Healthcare and Gender Equity, an online international monsoon school program, a 4-day immersive online hands-on certificate training course, I, Fiza Mahajan, visiting researcher at IMPRI, Impact and Policy Research Institute, would like to propose a formal vote of thanks on behalf of IMPRI, Gender's Impact Studies Center, New Delhi. We are grateful to our experts for day 1 session, Professor Poonam Naik, Professor Vibhuti Patel, and Ms. Sangeeta Rege, for taking out their valuable time and giving us an opportunity to learn from this online certificate program. And I would like to thank all our participants who have raised pertinent questions and have actively participated in today's deliberation. We look forward to welcoming you tomorrow at 6 p.m. for our second day of the certification course by distinguished experts, Dr. Padma Deosthali and Dr. Mala Ramanathan. We are grateful if you are watching us later on YouTube or listening to us on various podcasts or reading our publications. We hope you continue to join in future to improve web policy talk and web policy learning. I wish you all very good day. Thank you.
Thank you.